Thanks.
Dr. Ibrahim, I have one question. So, because as you are a pathologist, so while digitizing those slides, it will take a huge amount of data. So, just want to know what type of scanner are you using in your hospital?
So I actually have multiple scanners. Now, one other thing, we are a digital pathology conference. So I want to tell you is that digital pathology requires a lot of storage, a lot of computing. This is one of the largest files. You know, a digital slide can be 100,000 by 100,000 pixel. That's a huge file. And a larger resection specimens can be 2,000 by 200,000 by 200,000, more than 2 billion pixels in one slide. So uh, the scanners are almost standard now. I usually use either Roche platform. I have also KF Bio system that we are using, but almost all standards are either using a TIFF. Now we are using DICOM standards. But the problem is what you can do with these data. And I'm going to talk about it in my AI talk, Deep Learning in Pathology, how you can utilize this data, and it is not possible without cloud. You cannot do the computing that you need on a simple 64-bit PC. Even if you put 5 racks or 128-bit racks, no comparison to do computing that you need on these large images on in a normal PC.
So,
So
actually, what we are facing challenges that multiple scanner and what system you are using, we need to do a color calibrations. So that need to be checked frequently whether it is optimally calibrated or not, because we are using multiple colors, HNE, image or DAP or multiplexing fluorescence. So for that, a robust color calibration is required.
definitely.
For diagnostic purpose, while applying the AI algorithms, to make sure that we should be authorized or approved by FDA.
Perfect.
Cannot apply the algorithms which is not approved by the FDA and give them the report. It should always should be supervised.
Totally agree.
Thank
So
you.
this is what you're saying is interoperability.
Yes.
You have a data, you have one data set that you have trained the data on, is a specific strain of H&E, specific lighting, specific scenario. And when you bring the same case from another center, it's off.
Yes.
And AI is very sensitive, beyond human imagination. Like for me, the two looks exactly the same, but AI is able to pick minor color differences and it's going to go off. So I'm going to talk about it in more detail about interoperability of data, how you can use models that actually what they do is they two different colors of H&Es and they buffle them and they kind of make them interoperable. So there are separate models, AI models, that specifically are working on these aspects to make the model interoperable. So, just like we're looking at diagnosis as AI, we have models that actually work on how to make different shades of color interoperable.
It should be scanner agnostic.
It will be a scanner agnostic, not a scanner agnostic, H&E brand agnostic,
Yes.
whichever you're coming from. It will automatically take, it's a separate model, actually takes the different colors and merges together and gives you a product that you can use in any solution. Okay, please. Mm.
Set 3,000 images and we need to see them immediately. So how fast do the images get down? System of the packs to see those images with the cloud image.
So, you're dependent on that, on your bandwidth and latency. When you're signing a contract with the internet provider, you need to look at it. What is your bandwidth and what is your data
It
latency?
has not.
It has nothing to do with that. It is fiber optic line. Now, in radiology, you guys are very blessed. You have, the grids. You have the grids. The data are very accessible. An X-ray is 2,000 by 2,500 pixel, while a pathology slide image is 1 billion image. So the scalability and accessibility in radiology is way more powerful because
I just want to know.
it has to do with the SLA, service level agreement with the internet providers. Okay,
Thank you.
appreciate it. Thank you so much. Appreciate it.
Like to present yourself. Stay. Now moving forward with excellent set of speeches. Our next speaker is Dr. Hauda Ali from Saudi Arabia. And I will be passing her the mic and taking her to the stage to deliver her speech and to introduce herself briefly. Thank you, Dr. Howard.
Thank you. Good morning, everyone. I'm Dr. Hawra Al-Janoubi. I'm American board certified in oral and maxillofacial pathology. I had my residency training in Buffalo, New York. So today I'm going to share with you a very simple topic about a case of desmoplastic fibroma of the jaw. Desmoplastic fibroma, it's an intraosseous bony lesion. It's considered the bony counterpart of desmoplastic fibromatosis. It's considered very rare. There are around 160 cases published till date. It's a benign tumor, although it's locally aggressive. The incidence is very low. It's around 0.1% of all primary bone tumor. It has a predilection to the mandible, especially posterior mandible, and it also can occur in the femur, pelvis, radius, and tibia. It's commonly affected in young ages, below the age of 30 years of age. Clinically, it has that slow-growing, painless growth. And radiographically, it can occur as multilocular or unilocular radiolucencies, and it might have that well-defined or ill-defined borders. So now I'll share the case report. So this was a 36 years old female. She presented with a mild swelling in the mandible for 3 months duration. She was complaining of headache and ear pain in the same side of that lesion. She is HPV positive. Otherwise, she's healthy. On extraoral examination, she looked well and healthy, but she had that facial asymmetry. She had a mild left mandibular swelling. It has a hard consistency. On intraoral examination, we found buccal and lingual bony expansion, especially it was mainly on the buccal side. It involved the premolars and molar teeth, and there was also grade 1 to 2 mobility in these teeth. The overlying mucosa was normal. This is an OPG showing the lesion. As we can see over there in the left side of the mandible, it's well-defined multilocular radiolucent lesion extending from the premolar to distal to the second molar, and extending from the apices of the teeth to the inferior border of the mandible. And we can see the inferior border expansion and thinning of the inferior border of the mandible. Here's an axial CT view of the lesion. We can see there's a lytic lesion over there. It has a low attenuating, it's low attenuated, and also we can appreciate the discontinued, as we can see here. So this lesion caused a perforation of the buccal plate, and the internal structure of this lesion is heterogeneous soft tissue. This is a coronal view showing the same thing. Okay, so showing the same thing. That's the expansile lesion. If we compare it right and left, we can appreciate the expansion and the also the perforation in the buccal side. So the plan was to have an incisional biopsy and to be sent for histological examination. So this is the H&E examination of this lesion. It showed the periphery did not have any capsulation. It was poorly demarcated, infiltrative. There was sheets of uniform, bland, small spindle cell, and it was highly collagenized. Here is a higher magnification of the histological presentation. As we can see, it has that bland, uniform spindle cell, small spindle cell with wavy nuclei. It does have indistinct cell border. Also, the examined tissue showed highly collagenized, like small bundle collagens. So we plan to have some immunostains. So SMA was positive, Vimentin was positive, but I don't have the picture for that. S100 was negative. Desmin was negative. CD31 and CD34 only highlighted the vascular channels. So we reached a diagnosis of desmoplastic fibroma of the jaw. So the plan was to have a mandibulectomy because, as we know, this lesion is very aggressive. We can see on the intraoperative pictures the expansion caused in the mandible, and that's the resected part of the mandible with the 4 teeth. So this is a 3D CT images of 5-month follow-up. It showed good healing, good fixation of the plates. So coming to the discussion, so desmoplastic fibroma, it's a rare benign tumor composed of spindle-shaped cells with minimal cytological atypia and abundant collagen production. It have a slight female predilection, and in the literature, they have related to estrogen hormones. The mean age is 23 at diagnosis. It has a predilection to posterior mandible. Clinically, it might have slow or rapid growth depending on the case. Also, it might have some complication or side effects like it might cause trismus, disturbance in the occlusion, teeth mobility, pain, facial asymmetry. On radiographic presentation, again, it might have unilocular or multilocular outline, or it might have a well-defined or poorly defined borders. CT and MRI are very helpful to evaluate the extent of the lesion. As of immunostains, there are no specific immunostains for this tumor, but some stains that might be helpful is smooth muscle-specific actin, which is usually negative in most of the cases. Smooth muscle actin, positive in 70% of the cases. Beta-catenin is positive in like 50% of the cases. Vimentin is also positive, but S100 is negative. And it has a low level of Ki 76. Again, it has that aggressive nature, so it has a high recurrence rate, especially if it was not treated in the recommended way, which is a resection or in a block resection. So if the case was treated by curettage, high recurrence rate. Some in the literature also, they suggested the use of radiotherapy, and they end up with good results. But considering the transformation of the lesion to fibrosarcoma is also considered, and when using radiotherapy. So as a conclusion, desmoplastic fibroma is a rare benign locally aggressive tumor with high recurrence rate, with histological features that might be mistaken as other spindle neoplasm. Understanding the radiographic features correlated with histological features is very essential to reach a very accurate diagnosis. Here is some of the resources, and thank you.
Nice presentation, Hara. Just wanted to know how do you differentiate it from the fibromatosis? Means you presented the desmoplastic fibroma.
Yeah.
So how could you differentiate it from the fibromatosis?
From what?
Fibromatosis.
Fibromatosis.
Yes.
Because desmoplastic fibromatosis, it's usually because desmoplastic fibro. Yes. Okay. Okay. Yes. Okay. So okay. Yes, okay. So it is because desmoplastic fibroma, it's a bony lesion, while the soft tissue desmoplastic fibromatosis, it's the soft soft tissue counterpart. Also, beta-catenin, it's 100% positive in the desmoplastic fibromatosis, while it's not in the desmoplastic fibroma of the jaw.
So we need to see the local invasive component. Usually the fibromatosis is infiltrate the surrounding area. That in the fibromatosis, who is receiving this case. That is also one clue point out that
Yes.
on the fibromatosis.
Yeah.
Any questions from the audience? Okay, if there are no questions, something.
I have now gotten a pointer in case of next presentation, so I'll just connect it. Can you call that guy? The hotel guy? We will see how it works. Thank you. So two very interesting talks are presented by Dr. Ibrahim and Dr. Hamra, and we do hope to continue having interactive and excellent cases and talks further. Our next speaker is Ms. Noskova Karina from Russia. Can I call her on stage and request her to deliver her speech and briefly introduce herself? Thank you so much. Would you need a pointer? Would you need a pointer for your presentation?
This presentation is here.
I can think it's working. Thank you.
Sorry. Okay. Where my presentation? Where my presentation? Sorry. My presentation. Where? Presentation.
I think can you help her? Her presentation is not put up yet.
Get presenting. I'm here to help the translation tonight. Sorry. Да, здесь. Okay. Dear colleagues, thank you for this wonderful opportunity to present our work experience in this congress. My topic is about cytological differential diagnosis, mutant cyst lesions of the pancreas. At first, I want to say I have no potential conflict of interest to report. Increased use and recent advances in radiological diagnostic modalities have led to frequent identified of incidentally diagnosis pancreatic cyst. It is known that the prevalence of cystic neoplasm of the pancreas is from 2.6 to 15% and reaches 37% in people over ages. Accurate diagnostic of cystic lesions is important to determine the management, surgical treatment, or dynamic observation. This also determines the frequency and preferred method of observation. Our center
has 11 years of experience in EUS diagnostic cystic neoplasia of the pancreas. The report presents data for 7 years from 2017 to 2023. 921 US studies of cystic neoplasia of the pancreas were conducted. From this, in 22.6% of cases for the purpose of differential diagnostic, the application of additional research method was required. The method are contrast enhancement, confocal laser microscopy, and fine needle aspiration. According to international guidelines and algorithm for the management of this lesion of pancreas, excision of the main pancreatic duct more than 5 millimeters, enlargement of regional lymph nodes, increased level of 99 Cs, size more than 3 centimeters, unilocular formation. Okay. Molecular formation, thickening of the wall or septum, the presence of the solid component in the cyst wall are worrisome features and may require EUS-FNA for morphological verification if this change the treatment management. In our study, EUS-FNA was needed in 5% of cases. From 2015 of 2022, we use the 6-level terminological system of pancreaticobiliary cytopathology of the Papa Nicolau Society. Mucinous cyst neoplasia and intraductal papillary mucinous neoplasia were included in the neoplastic event category. The co-reporting system from pancreaticobiliary cytopathology was published in which mucin-producing cyst neoplasm are divided according to the degree of cytological atypia, category 4, low grade, and category 5, high grade. Two-tiered categorization system for epithelial atypia has been proposed for FNA of pancreatic cyst to stratify the risk for high-grade dysplasia or carcinoma within a given lesion. Besides the two-tiered categorization of epithelial atypia and pancreaticobiliary cytopathologic samples match the two-tiered histopathological classification of intraepithelial and cystic neoplasia in the fifth additional classification of digestive system tumors. When reclassifying 67 cases of the cystic neoplasm, we see non-diagnostic category are 9%, benign 11%, category low grade 15%, category high grade 12%, and category malignant 51%. In all cases where it was possible to obtain cystic fluid, CEA and glucose as marker of mucin production were identified. Amylase less to sorry, 250 may include pancreatic pseudocyst. In this specimen, even with the absence of an epithelial component, but with clear evidence of mucin, for example, CNA more than 192 and or glucose less than 2.7 and positive alkyl blue stain was classified as low risk category 4. In our research, such 6 cases were identified. The other 11 cases were identified according to the degree of mucinous low-grade dysplasia, 33 present, and mucinous high-grade dysplasia, 67 present. Accurate grading of the epithelial atypia as low-grade and distinguishing it from high-grade atypia is challenging and requires a well-preserved epithelium and diagnostic experience. The samples were reviewed by 3 doctors who experienced in pancreatobiliary site pathology for more than 3 years. It is known that there are no features that can cytologically distinguish between MCN and APMN. It is important to determine the degree of dysplasia. A specimen classified as pan-low has evidence of intraductal and or cystic neoplasm with a low grade of epithelial atypia. Diagnostic cytopathological features, low-grade dysplasia. Usually low cellularity, variable amount of thin or thick mucin, blunt augmented atypical epithelial cells in small sheets and tissue fragments or thickly columnar or cuboidal epithelium cells about the size of the duodenal enterocyte in small tissue fragment, round or oval with nucleus smooth of mildly irregular nuclear membranes. Now let's have a look at some clinical cases. Here you can see cases number 1, female, 26 years old, medical history, pain in the left hypochondrium, enlargement of the abdomen on the left, imaging finding cystic lesion in tail of pancreas. For differential diagnosis, the EOSFNA was performed. The specimens show scattered cells of slightly atypical cuboidal mucin-containing epithelium with smooth, predominantly centrally located nuclei, slightly altered nuclear membranes, and evenly distributed taking into account the distribute permitting in the background of the extracellular mucin. So, cytopathological report satisfactory for evaluation, MCN low grade, category 4. Taking into account large tumor size and pain syndrome, laparoscopic caudal resection of the pancreas was performed. Morphological research, a mucinous tumor of the tail of the pancreas is low grade. The next cases. Female, 75 years old. EOS imaging in the body entail the neoplasm associated with a dilated branch and the pancreatic duct. In the head, there's a lesion with clear or uneven contours. For differential diagnosis, EOSFNA was performed. You can see in this sample we have sheets and papillary structures of columnar mildly atypical mucinous epithelium. Satisfactory for evaluation, IPMN low grade, category 4. Taking into account the ultrasound image was utterly suspicious for carcinoma, laparoscopic distal corpocudal resection of the pancreas was performed. Morphological research, IPMN type 3 of the pancreas is low grade. Of all the criteria for low-grade dysplasia in our study, most significant were columnar cuboidal epithelium cells about the size of duodenal enterocyte in small tissue fragments, and round oval with nucleus smooth, mildly irregular nuclear membranes, evenly distributed chromatin. Now let's have a look at high-grade dysplasia. Key diagnostic cytopathologic features: hypercellularity, small cells smaller than a 12 duodenal enterocyte, increased in serratia, nuclear envelope abnormals, abnormal chromatin pattern, and so on. The next clinical case is female, 39 years old, is identified IPMN of mixed type with the presence of intraluminal solid grown of the main duct. For differential diagnosis, FNA-OS was performed. You can see capillary tissue fragment of composed of small cells with high in serratia, irregular nuclear and coarse chromatin, a hyperchromasia. Cytological report satisfactory for evaluations. A neoplastic mucinous cyst with high-grade dysplasia, category 5. Histological report, a payment with high-grade dysplasia. The next case, female, 36 years old, EOS imaging. The cystic neoplasm of the pancreas tail with solid component is in the cyst wall. For differential diagnosis, USFNA performed. You can see the specimens show mucinous epithelium in the background of the extracellular mucin. Scattered epithelial group demonstrate high-grade atypia with high in serratia, hyperchromasia, and nuclear membrane irregulars. Cytological report, a mucinous cyst with high-grade atypia, category 5. Laparoscopic distal corpocudal resection of the pancreas was performed, and morphological research, MCN, with invasive carcinoma. In our research, significant diagnostic of high-grade dysplasia were increased in serratia, nuclear envelope abnormalities, and abnormal chromatin pattern with can be hyperchromatic. In conclusion, again, I would like to note the importance of determining the degree of dysplasia, since this has significant for treatment management. Cytological grade, according to the World Health Organization definition, demonstrates that the absolute risk of high-grade dysplasia of suspicion and positive result and 100% and therefore suspicion and positive result and include and high-risk strata cured guidelines. And certainly, I appreciate the assistance of my team in preparing the report and for teamwork. Thank you for your attention.
Thank you, Dr. Naskova. Please introduce yourself, where you are working.
My name is Irina Naskova. I'm head of laboratory of Moscow Clinical Scientific Center named Loginov. I'm a cytopathologist.
Thank you so much for sharing interesting cases. Does anybody in the audience have questions? Dr. Pradeep, do you want to ask any question?
I have some comments. Actually, it is pretty difficult when there is a low grade dysplasia, especially in US guided FNC to diagnose low grade dysplasia. So first of all, we need to look for the PET scan report or any other radiology report. Is there any molecular nodules are there? The sizes should be more than 5 millimeter. That is one aging point. Also, pancreatic enzyme level we have to check. And third thing is that we need to check for the chronic pancreatitis, whether the patient is suffering from resistant chronic pancreatitis. If there is inflammation, that inflammation can add up to the dysplasia. That's called as inflammatory atypia. So that inflammatory atypia can upgrade your dysplastic reporting. Means if you are trying to report as a benign, the inflammation can lead to nuclear enlargement. So you might put that into a low grade or moderate or maybe high grade dysplasia. So those things we should keep in mind while reporting the cytology report.
Okay, thank you.
So we'll be having a coffee break now. I think the coffee break is continuing till 11:20. Dr. Noskova, can I give you your certificate, please? Coffee and refreshments are at the end of the room. Kindly help yourself and we resume at 11:25. Thank you. There's a group picture also, as I'm informed right now. We all will gather there and just have a good photo as a memory of this wonderful meeting and networking. Thank you.
We have a group of
You need to log in.
I'll sign.
Sure.
This become more lazy. So can I log into my, this has internet?
Yes, yes.
Just off it.
Yes, proceed.
Oh. Mouse.
Okay.
Can you just close this?
You just press the switch to do.
So the speaker slides, they're all here, right?
Yes,
Okay.
but they will be removed.
Just want to double check, see whether my PPT is here.
Your PPT is here. You are a chairperson. You're supposed to sit there. I'll introduce you.
No, it's okay. It's okay.
You should sit there because you were looking for you.
Oh,
So
okay.
please sit with
I
us.
came late.
No, please sit with us. I'll introduce you.
Okay.
Yeah.
25, right?
Take your credentials. It's okay then.
Oh, yeah, I sent it to her. I emailed her.
Which PC is this? This
I emailed it twice.
Sorry, but
can I send those two slides on your email? It's not, my email is not opening. It's a security thing. Because I didn't bring my other phone. Is there any other email I'll send to you? Tell
yeah, you
me
can just send to
which email ID is this? Okay. Okay.
only 2 slides.
Yeah. Images, not even sites. Sure. 21. This is right.
Yeah. So other things you have in your pen drive.
Yeah. Okay. Thank you. Yes. Just download. And put.
One will receive.
Yeah, when is it?
So should I keep it in that folder?
Yeah, and I will delete my presentation. Yes. I can present directly
Yeah,
to the
you
metro.
can, you can present directly from you. If it won't work, so it's better paste it. Later on you can delete it.
I don't need to find them.
You keep it here later on after presentation. Or you are doing the chairing, right?
Yes.
So during lunch hour you can delete it
Okay.
before going for the lunch.
Yes.
Because most of the time, if when I want to work, then
Yeah,
it's
no, absolutely, I understand. How
I
do
kept your image in that folder. I can close this presentation.
where is the
Please
photo?
close all the rest of the presentation.
No, I'll close.
Where it will-
I think all are closed.
Yeah.
Check.
So do you want to read that this
Yeah.
images?
Yeah. Let's open it. First, we need to open and then copy. Let's just make it short. Yeah.
And this file,
This one, yes, perfect.
you send it to the mail?
Yeah, we'll remove this.
There's no.
I'll look at. No, no, I'll try to remove them.
I'm shooting for it.
So
It was like this fighting when I came here. It was like, you tried to hold it. Chinese. It was there. Yes. It is like, you know, this. Just. Yeah. Yeah. Yes, we do. In the north, yeah. Can go to the table, Sydney. Situation. See, many men work this. Say what? Just. So it's yes. Yes. This is like a whole and justice or something else. I think the case we see in the this week and all these. Ages of yeah. You can imagine the actual thing, right? It's just like, yeah. Yeah. It's over crazy.
So I sent the latest one yesterday. Yeah. Yeah. Very good. Oh, it is coming there.
You can have a look.
Hmm.
Once you are done with the checking, you can close it.
Yeah.
Okay.
What I changed. Okay.
It's
Is this?
yeah, please. Yeah, you can have it.
What do you put it? Calling about it? Oh. Yeah. Yeah. It's fine. Then you can. I'm gonna give it. So that is important to do the patient. I think to chart and what to work. That's what personalized treatment is all the documents. And it's too much of the question is that care and to mental environment control. It's not just environment. Community, chemicals and metals are there. For 9 years, so there's and knowledge realization. This is knowledge that new the less process still especially the need and the not the oil and all of those things. Yeah, so it's like that. With all these switches on down the train, and they changed everything, changed the behavior and people changed it. I did according to that, and now they do that. So we're not like it's like that. Yes, we just I couldn't use it. Did not use to be school and not able to pause or will to resist and research. Even the dynamic meditation has still certain good on expiring earlier than the current. Again, like began here, that. That actually was okay, let's see. Okay, what's related to scale? And the really funny stuff. It's fun. Oh, yeah. It happens every time. Yeah. That motivation being from everything it's not just I don't know why. I will never have to know. Of course not. That's easy. Well, what is it controlling? Us team. Oh, I see. Yeah. Yeah. Same thing. Look. And he's like, he's in school. So that's how musicians. It's okay. By the way, I know if I told you. Did I tell you? What you do I don't think you just know. I told you about what you do. So that's it. Or nothing. We'll have it all good. That's good. That's cheaper. Yeah, that is it. Yeah. Yeah, it's one of the people. Absolutely. I can adapt anything. My confidence. And just because it's school, you have to do it for everything. Yeah. It's so it's not over as a country. Like, I'm sure. Yeah, that's the only reason. Because I wanted to get them to go. Usually, I like the energy. Sometimes I worry it was especially with patients like like learning stuff. I don't know, but then I yeah, it's right. You're also right. That's what the case is. Already she is. The thing is that I keep building this way. This is where the same lost the balance. I feel different. Space of branches. You could literally run. I was just like, it's not kidding. Yeah. So it makes it's super big. Just
Yes. So it's like not I do. Yes, but it's surgery. So we was the guys that you see there in the room of prison. We know it's wrong. The rest of the there was going to be there for them. Yeah. Yes, the group had the same. It's also because like the United a lot of students with that sort of branch. And also they're communicating mostly fields. I can't know. Yes, I'm going to realize. Yes, I'm going to agents. That's not general. Inside positive. You see that it's really well. It's cheap. Well, it's like no, I didn't say it. I said you're so keen about it's the new services in the hospital. Why? Because there was and if you the same. So I guess that's good. They're very nice now.
Yeah, you need.
I don't have so really, when you were working with other employees, me, and I don't know, yeah, I'm thinking there's some fields I do, like I'm really interested in like surgery, that's interesting. Like orthopedics, those are all obvious, right? But like I like this because I saw about I also use like the progress in cardiology. I think like interventional cardiology. To see okay, so surgery, general surgery, also so I you did it seems quite cool.
So much time, that's all.
Yeah, that's all of them. I don't know. Oh, 2 weeks ago, ako Bye. Just take a camera. Oh, I'm right there. I'm there. It is like, can you also send me a Gastro? Yeah. We'll see. Because patient got do it for a very, very. It's always like common cheap. Because it's not one that's out there, like so. We need to be good. Yes. Following a separate thing. Yeah, exactly. It's not really happening. But it's very difficult. It's also because it's a difficult. It's like happiness. Everybody doesn't. It's like all of the comparison plus the and the I guess it's equally feel I feel like whatever election we do. We can set people to review and I realize the truth thing. That's it. Originally. That's it. It's a culture. See, I think it's things not moving in that direction. If you were saying coverage, it's not required to celebrate. That's great. Coming. Great. Let's connect that with fishing. Thanks. I feel like getting into it knowledge, very like you like you like these children. Yeah. I would try to should know. Video, but keep in mind, slate load. I have ideas, but I don't know, and I want to.
Like on channel.
That's if you're doing every single, yeah, maybe you think I'm great for aspiration. You picture me in every single. I see like I for example. like ortho.
Oh my goodness.
So every
And they want to.
yeah, they. Ask him, no one has saying like how to listen to my order. It's very probably my question. I ask you later. You can understand what happened. So, she did everything because I can talk about it. Nothing like so I didn't mind I'll say ironically it up in like in India the weed without the chest. That's great. And the guy organized. You know where my gosh, there's something that no, because it's specific to guys, because that's so because all the stations like you remember like on me my no, which is so you have like 7 you this was like you was there's so much more on the way there's so much awesome. Yeah. No, stays. Wait, let's kind of look. You know, I'm not sure what it is. Why is that so? Yeah, but like I'm showing it. But everything is like because how many geriatric killers like yeah, look at it. That's all. Let's do one check. Or like I was saying, cervical surgery or neurosurgery. Maybe something like audio, like for someone does another research. So you almost like you know. But I was thinking because I
Excuse me. Coming, I don't know who's coming. Yeah.
So our next speaker is Dr. Sweta Agarwal. She is a radiologist by profession. So she has 2 decades of experience in breast imaging. She is a qualified international committee member for European Society of Breast Imaging and board member of examiners of in EDIR. And she is right now practicing in GMC and a radiologist expertise in breast imaging. Over to you, Sweta, for your talk.
Good afternoon. Good morning, everybody. It's still morning. It seems like a long day, but still morning. I hope people here with pathology experience would have more idea about the slides that will be presented. It was courtesy of my colleague who's practicing breast radiology, breast pathology solely, and looking at breast cancer slides. So she has been very courteous and given me the slides of the patients that we had sent after biopsies. So when we practice breast imaging and breast radiopathology, sometimes it is difficult to have concordance between the imaging as well as the pathology. We need to have what we are seeing in radiology, the pathology matches, otherwise the follow-ups, excision, all these things become, for the patient, sometimes they become non-compliant because it creates a lot of emotional hassles for the patient as well as it becomes time consuming. The most challenging thing that we face in breast imaging is not usually cancers because that's a straight up diagnosis. We would do immunostains, we would know what type of cancer is it, whether it is surgery first or whether it is chemotherapy. The challenging lesions are B3 lesions, which are indeterminate lesions. For B3 lesions, till now we have had 3 international consensus how to manage these B3 lesions. What are the practical issues and the international consensus? I'll be discussing this in brief, and you will see during the slides why it is challenging because UK practice is much different from rest of the world practice. UK practice does not really match what is done in Europe and rest of the world. So then it becomes challenging, especially we have patient coming from UK, we have pathologists from UK, we have surgeon from UK, but the patient is from Germany. The German outlines for B3 lesions management is different. The UK management is different. Now, as a radiologist, we are stuck. Should we send her for open excision in a B3 lesion or should we send her for a minimally invasive vacuum assisted excision? So we'll go through the slides slowly and I'd be happy to answer any question and stop in between slides. So what is the most common concern about B3 lesions? They are having an uncertain malignant potential. There are multiple studies to show that certain B3 lesions have a malignancy upgrade rates which range from 8% to 30%. But that's a huge range. They can be varied. And which patients upgrades, we don't know. So what is the treatment management for such patients? Now, associated in situ or invasive cancers, in certain, the highest rate goes from 20 to 30%. The most common upgrades are for ADH, atypical ductal hyperplasia, and LCIS. So most common in the radiological practice, the inclusions of the B3 lesions are phyllodes tumor, flat epithelial neoplasia as FEA most commonly called, atypical lobular hyperplasia, LCIS, ADH, intraductal papillomas without and with atypia, and radial scars, again without and with atypia. Of these, trickiest are intraductal papillomas in radiology. Because they are small intraductal lesions, even if we take, usually the practice is to take 4 samples when we do biopsy, but even after taking 6 samples, there's a small amount of atypia that can be missed on biopsy. If we go on vacuum assisted excision, we may find atypia. Now, after vacuum assisted excision, have we removed all the atypia? Does it flourish again? Do we have more areas of atypia? Do we do open excision? Do we do follow-up? So these are concerns, especially as a radiologist. There are few other lesions not very commonly seen. Mucocele-like lesions, apocrine atypia, vascular lesions, and bland spindle cell lesions. In my 20 years of practice, I have only seen 2 vascular atypias. Those patients decided that they will not go for vacuum assisted or open excision. They were very scared that vascular lesion will bleed like anything and there'll be a lot of mess. So she's still on follow-up and she's okay by God's grace. Now, B3 lesions are reported in a varied manner in different centers because of the footfall of the patients. The moment they see there's something, they would prefer to go to a tertiary center rather than a center. Sometimes they will just fly over to their own countries. We are living in Dubai, where we have mix of nationalities. Not everybody may have access to insurances here. So many times, and these cases are all from my practice. So what we have seen, and all over the world also, patients decide what they want to do. Not necessarily, even if after their surgeon's recommendation, it is not necessarily because they know the upgrade rates are right from 8% to 30%. So the moment they realize it is 8%, everybody wants to be on the lower side of the risk. They have a positive input. Very rarely our patients see that I can be in the 30% risk. So many don't go ahead and do anything for those things. Now, what are the upgrade rates? This is a very busy slide. There are the highlighted in the red are the ones which are the studies that have run the longest, 11 years, 12 years, and 14.5 years. Very interestingly, the largest number of cases are in an Italian series, almost 26,000 cases. And the world-renowned cancer center, MD Anderson, it has only 5,000 almost cases. But again, the upgrade rates are almost comparable. The highest upgrade rates are seen in the Italian series, which is 21%. In MD Anderson, we can see it is almost 13%. There is a gap, but again, the practice in the US is more conservative. They don't necessarily go for excisions, which do change the upgrade rates. Now, there is another group, which is minimally invasive breast biopsy group. These are the upgrade rates. I have made the table from the journal. So the highest upgrade rate is in atypical ductal hyperplasia. Although I see that, not highest upgrade, the maximum open excisions. When we call as upgrade, when we have had a biopsy, the biopsy has said a B3 lesion, the person goes for open excision. On open excision, it comes as invasive cancer. Now, the maximum open excisions are in atypical ductal hyperplasia. Although upgrade rates for LCIS and ADH are comparable, both of them are around 25%. Still, ADH is considered higher risk. So that is still debated among radiologists. As radiologists, we feel that LCIS should also go more frequently for open excision. However, now the practice is changing to vacuum assisted excisions. But surgeons prefer ADH, that we have to get ADH sorted faster because ADH converts into DCIS more frequently. LCIS would convert to lobular neoplasia. The dilemma across B3 lesions for any person who's practicing breast imaging or breast surgery or breast pathology is one, if we have a core biopsy with B3, do we excise it at all or do we follow up? Now, there are two ways of excising. Is it a minimally invasive outpatient procedure, which is vacuum assisted biopsy, which is hardly takes 45 minutes to 1 hour, depending upon the size of the lesions, or open surgical excision, which comes with its own risk of anesthesia, inpatient, the patient is not having a family around to take care of them after the surgery. So there are a lot of constraints involving both of these things. The third, and very importantly, once I have done vacuum assisted excision, should we still go for open excision, especially for ADH and LCIS, because the upgrade rates are in the range of 25%? Or should we just follow up? In the current practice, despite having these questions, we are following up if we are satisfied that we have excised the lesion completely. And these patients are called for ultrasound follow-up every 6 months. If vacuum assisted excision is for flat epithelial neoplasia, which has calcification under stereotactic guidance, we do mammogram frequently for them. We understand the radiation, but we do only the concerned breast which had calcifications. Now I'll briefly go through the different types of B3 lesions. If there is any discrepancy in the slides, which the eminent pathologist would see, please forgive me because these are the slides that are given to me as a courtesy. So very important point is difference between ADH and DCIS by a size difference. The idea that ADH would have calcifications is not necessarily positive because almost 70% don't have calcifications. We cannot detect them on mammogram. If we use a higher gauge of needle, the upgrade rates are lower because it excises more tissue. So usually when we take biopsy, it is 12 gauge needle in our practice. Many people use 14 gauge. But the lower the gauge, the upgrade rates are lower because we have already excised a lot of sample. Now, if we have removed enough specimen in vacuum assisted excision, the criteria is 4 gram, then vacuum assisted excision is an alternative to open excision. Many times we are not able to completely excise it. One, because it is vascular. We have, in my practice, I have at the patient, it was very close to a vessel. Now, vacuum assisted biopsy needle is 7 gauge. The moment I go close to that vessel, it is going to bleed torrentially. We don't want that field to become bloody and then we end up removing the hematoma and still we have residual region. So we try to excise as much as we can. If we have a residual lesion left because of vascular nature, we inform the surgeon, we follow it up. In case there's any growth, any vascularity, any new irregularity, it goes directly for open excision. We don't do any more vacuum assisted excision for it. Now, the risk of developing contralateral or ipsilateral cancer over 25 years of age is almost 30% for ADH, and that is why yearly mammograms and ultrasound every 6 months is recommended. Now, this is one of the cases. This was actually a video where I have marked in orange. I'm not sure I'll be able to point it. The pointer is not working, sorry. So the yellow ring is marking the, so this yellow ring is marking the area of architectural alteration. This was a lesion which was slightly vascular. We did the biopsy, it came as ADH. This was the slide that was given to me, and it is mentions that there is nuclear atypia and complex architecture. This was ADH in this patient, and still we are doing follow-up for this patient after vacuum-assisted excision. She is fine. She is happy to do the follow-ups, and because she is at a higher risk, her daughter is at a higher risk, the family members are also coming for evaluations. A very interesting lesion is flat epithelial neoplasia. I have not seen them a lot in my practice. So they are associated with calcifications, and their immunophenotype is associated very closely linked to low-grade DCIS. The upgrade rate, as I mentioned earlier, is higher on core needle biopsy, especially 14 gauge needle is used. However, with vacuum assisted biopsy with a 7 gauge needle, upgrade rates are low. So now here comes the difference among different institutes. Now in UK, especially with the tertiary centers, they are not doing biopsies. The moment they see there's a calcification, there's slight irregularity, let's go for vacuum assisted excision. They do a biopsy when they have open excision. They say our upgrade rates are lower. But if it is elsewhere, it's a biopsy, the upgrade rates are 30%. That's a huge difference of almost 29 to 27%. So now what are we supposed to do? Here, the guidelines are still into making that we unify it across the world, which is again difficult, but we are trying to reach there. So why we are giving the guidelines? Because it depends upon the age of the patient. Any presentation in the imaging is discordant with the pathology. If imaging is more concerning, the patient goes for straight away, either VAE or for open excision, preferably VAE. Now, if there are follow-ups, they are regular follow-ups, and the most important thing is by visual assessment. And here the radiologist experience comes into view, because we visibly have to understand that more than 90% of calcifications are taken away. Now, somebody in the conference was asking me about my experience with AI. So very interestingly, the AI that we use, and it is used in Europe and US, it doesn't pick up calcifications. It picks up architectural alterations, but calcifications they miss. So we don't rely on AI for calcifications. It is our user experience, the more experienced the breast radiologist, and we do double reading for these things so that the patient gets a better report. Now, the instances where we have pathological radiological discordance, we have a mass lesion of a particular size. Usually it is 1 centimeter, but we reduce the margin to 8 millimeter. If the mass lesion or residual calcifications, at least 4 to 5 in number on mammogram, we straight away ask for open excision to the breast surgeon. Then the breast surgeon and the patient discuss whether the patient really consents to open excision or not. Now, this is a case. We did a mammogram. I'm not sure the calcifications are seen. I have tried to highlight this is the area where are clustered calcifications. So the criteria for calcifications on many people have calcifications. What is the criteria of microcalcifications which go for biopsy? More than 5 in number, clustered, associated or not associated with the mass doesn't matter, but they are supposed to be clustered and definitely more than 5 in number. Pleomorphism or not pleomorphism, again a questionable criteria. The pleomorphism develops a little later, but the cluster develops earlier. One thing that I've seen in practice, we had 4 microcalcifications in one of the patients. She came almost 2 years after, despite having a family history, not having an annual follow-up. The calcifications were clustered. They increased to 8 in number, but they burst open. They got arranged in a circular fashion. So they were rim of calcification. Seemed awkward over 2 years why this is happening. We did a biopsy and it was an invasive cancer. So calcifications are very important to understand, and here the double reading comes into play. This was a stereotactic biopsy with 12 gauge needle. We have not done stereotactic VAP. We did a stereotactic biopsy. And this is the slide of the same patient where monomorphic low columnar epithelial cells with lack of appropriate polarization. I'm sure pathologists will understand these terms more. This is all alien language for me. But this is a beautiful slide, as I'm told, for this case. The other case is classical nobular hyperplasia. Now, what is LCIS and what is atypical lobular hyperplasia? LCIS is when more than 50% of the SNI are involved, and ALH is when less than 50% are involved. Now, again, how much sample I have taken? How much sample is studied? Because I'm sure while making the slides, all of the slides are not studied. So are we making 50% diagnosis because it is actually 50% less or 50% more, or we are because of difference in user, different users have different criteria. I can do different biopsy. Some other person can do a biopsy in a different manner. Two different pathologists may have different opinions. The immunohistochemistry of these lesions are E-cadherin, beta-catenin, and P120 loss. In contrast to morphological variants of lobular neoplasia, the pleomorphic LCIS, florid LCIS, and type 3 or grade 3 are B5. They are graded as cancer, not B3 lesions. Now, whenever we have samples, what do we discuss? Especially when the patient is coming for lobular neoplasia. This is in my practice and in UAE, we do think lobular neoplasia should be excised. It should not go for vacuum-assisted excision. But again, because this is a place where radiologists and pathologists are coming from different part of the world, the practices differ, despite having international consensus in place. So UK recommends vacuum-assisted excision over open excision and then follow-up. Rest of the world, it is open excision. In most cases, invasive cancer occurs usually in the same breast. Still, the contralateral breast, the risk is increased. So I have mentioned the risk 60% and 25%. They may alter depending upon the family history, the demographics, all these things also come into play. Now, this is a very important slide. As you will see, I'm showing this cluster. And we have done stereotactic biopsy. I'll try to go back again. Let me show you. This is the cluster, right? We try to target it in stereotactic biopsy. And the stereotactic images not necessarily match the mammogram images because we try and place it so that the patient has the least discomfort. Mammogram is, especially the stereotactic biopsy, is uncomfortable. And I'm not sure if you're able to see, there are tiny calcifications at the edge, and we were able to take the calcifications. So this is the pathology slide. I don't have the description of the slide, but I'm sure pathologists would be able to understand what they are looking at. So this was proven to be lobular neoplasia. It was not high grade. The patient still went for open excision. She said, I want to be free of any risk. Might as well do my mastectomy. And no, I'm not going to do that. Let's do an open excision. And she had a local excision and she is fine still, coming for follow-ups with us. Now, very interesting lesions are, as I told you, these lesions are papillomas, can be atypia, without atypia. I find this very tricky because when I'm reporting, I see intraductal lesion. Many times in biopsy, it comes as stromal fibrosis with milk inspissated. Without doing a biopsy, we are not sure what will be the pathology. Now, solitary papillomas are completely benign. However, if there is a ductal architectural alteration, if they are associated with any other atypia, then they go for vacuum-assisted excision. Now, why, again, vacuum-assisted excision I find tricky in the practice? Because they are very close to subalar region. Now, close to subalar region, the vacuum-assisted biopsy, we need to have a margin. So we need to tweak our technique for vacuum-assisted excision in a manner that we are not eroding the areola or the nipple. So these cases become a case, either we have to completely excise, we are able to completely excise. If we are not able to completely excise, they will definitely go for open excision if at all we have any radiological features saying like there is vascularity. I see a lesion with slight irregularity. My biopsy may have come as benign, but I still know that it is having slight irregularity, which may not have been biopsied or it may have been missed. A small sample would be there. So we still prefer, if we have radiopathological discordance, that these lesions go for open excision. Now, the risk of subsequent breast cancer is 2 times higher in patients with papillary lesions without atypia and 5 to 7 times higher in patients with papilloma and atypia. Open excision or therapeutic vacuum assisted excision following core needle biopsy, especially in papillomas without atypia. If target lesion is completely removed, the whole panel prefer the panel of people who were in international consensus that will do only radiological follow-up. But again, if there is no radiopathological discordance. Now, very interesting case. It was detected only on ultrasound. So this patient had this duct, a small speck of vascularity within the duct. We did an MRI, very tiny lesion on MRI, enhancing lesion. It was showing washout. I'm not sure this washout is understandable, but we make the curves. It is a rapid inflow and then it washes out, which is very typical of a atypical lesion or a cancer. This is another lesion. So this was the irregular lesion. The biopsy came as papilloma with atypia. Okay, let's do the excision. So between diagnosis, biopsy, and pathology, a MRI was done. So this patient had a lesion which was enhancing it. If you go on, if I show the previous slide, there's a linear enhancement, very nicely seen and everything. On this case, it was slightly irregular. Even on ultrasound, I can see the deeper margins are irregular. So when pathology came as papilloma with atypia, we asked for open excision and it was encapsulated DCIS, which was very surprising. The patient was just 35 years old. She has lost to follow-up. She doesn't live in UAE anymore. I think she has moved back to her own country, but interesting case. Now this is another lesion I have tried. This is an old slide, 2017 slide. So these are the lesions, irregular, heterogeneous. You see, this is the enhancement. This is very typical of suspicious enhancement on MRI. And this is intraductal papilloma with metaplasia. It did not have atypia, but when we are looking at radiology, it was little concerning. Patient refused VAC, patient refused the open excision. She said, I'm fine, and she is fine by God's grace. The other lesions that are huge lesions, not to be missed, palpable, are the phylloid tumor. They range in size. Whenever I have seen them, they're always more than 1 centimeter. They can be biphasic, they come at a younger age and then in a perimenopausal age. Now, these lesions have a risk of local recurrence around 10 to 20%, and sometimes it is 30% at borderline of malignant tumors. The papillary tumor, the phylloid tumor, which are found by core-needle biopsy, because of the size, it is very important to excise them by open excision because VAB has a criteria. Any lesion more than 2.5 goes for open excision. VAB will cause a huge hematoma and seroma in that place. So if we have by chance found it on VAB, it is just a small focus. We don't do anything for that. We believe that it has already been excised. Now this is a lesion which was, I think, 6 months ago came in our facility. Vascular, heterogeneous. These are two different cases. Vascular, heterogeneous, and irregular. This one is even more irregular. I did not expect this one to come as phylloid tumor. I was expecting a more B4, B5 pathology, definitely not a B3 pathology. It was benign phylloids. Sorry. The most common lesion that I see in my practice as B3 lesion are radial scars. Every 4th or 5th biopsy that I do is a radial scar, complex sclerodermal radial scar. And sometimes we feel it is a radial scar on mammogram. It comes as, lo and behold, invasive cancer because nothing else is there. I don't see anything on ultrasound. Everything is only on mammogram, no calcifications. So radial scars, again, the moment I see any scarring lesion, definite biopsy without wasting time, then we decide whether, mostly we do vacuum assisted excision for them. Open excision we have not performed for any of these cases. And international consensus, this is a very interesting point because for the first time, UK and international consensus are the same, that let's do vacuum assisted biopsy in a case and then just do a follow-up. So this was a case. I have tried to highlight the area that was interesting in the mammogram. It was, again, we discussed as radiologists Even though AI did not pick it up, we thought we don't find it nice. We'll try to find the lesion. We correlated it with ultrasound. On ultrasound, it doesn't look that bad. On mammogram, it was looking more of architectural alteration, but we could correlate it. We thought we'll do biopsy under ultrasound guidance, still a young patient, and then we will do a post biopsy mammogram to see that the clip is exactly in the same region. It did come as radial scar. Patient went for vacuum assisted biopsy, but not with us. She went somewhere else, and she's doing the follow up there itself. Now, why we have recommendations in place for an open excision instead of surveillance? One, when there is, again, histology and radiology discordance. Open excision is performed or repeat VAP is performed whenever there is a large lesion. For an ultrasound guided VAP, the size should not exceed 2.5 centimeter, as I have said, because it will lead to large hematoma and seroma. Sometimes the vacuum assisted biopsy is replaced by macrobiopsy because it takes larger sample. 4 gram is one of the criteria for the sample, and the needle is 7 gauge. However, the larger the gauge needle, the upgrade rates are lower. And again, when we talk to a pathologist, a person who has been dealing only with breast imaging and breast pathology have slightly more experience. With them, the upgrade rates in our practice are lower. Now, current guidelines are again challenging because, thank you, I'll be very quick. So current guidelines are challenging because traditionally it was open excision. Slowly, because vacuum assisted excision is still new, many people do not have the expertise to do it. So there is a overlap between the management. What are the issues? Again, ADH LCIS size criteria. 2 millimeter, more than 2 millimeters, how do we do it? How do we follow it up? That is why 2 millimeter, better go for an open excision. Whether ATP has been reported, do the two pathologists do they have their consensus in the findings? Did the marker go somewhere else, or the marker was placed wrongly, or did we target a wrong lesion? Because when we do VAB, the lesion comes in pieces. We are not having a complete excision like we do an open excision. So is it adequate? Did we get the entire sample with ATP included? And again, discordance, because repeat VAB is in UK, and overall everywhere in the world, it is open excision if there is discordance. So take home points, and this will be my last slide. Take home points that most important for ADH is always open excision, because less than 2 millimeters is ADH, more than 2 millimeters is cancer. Then for phylloid tumor is open excision. For rest of those, it is mostly a debate. UK it's VAP, and rest of the world is open excision. And I would like to finish my talk over here, and happy to take any questions except for pathology slides. Please forgive me because I don't know much of pathology. Thank you.
Thank you, Sarah, for your insightful talks on breast cancer, especially the radiology. Just one question. Do you incorporate BIRATs in your interpretation?
So in our reporting, it is mandatory whether it's BIRATs 1, 2, 3, 4, or 5. Usually, because the patients see our reports, we don't write BIRATs 5. We tell the doctor, but we don't write BIRATs 5. We keep it to BIRATs 4B. But to the doctor, we tell, because the moment patients see it's BIRATs 5, they flip over. So even if it is BIRATs 5, patients receive a slightly tweaked report, but we have to incorporate BIRATs categories in our reports.
I just have a small.
Yes,
Thank you
Dr.
so much for a very nice presentation, especially.
Do you want a mic, Dr.
Yeah.
Ibrahim?
B3 lesions are very, very tough. No, they are.
I completely agree to you. I agree to you.
And it is one of the areas that you really need to work on it. So I have a few things from the perspective of pathologists, and we
Right.
did that game plan.
Definitely, it will be insightful for us.
So what we do is that for B3, B4 lesions, we have a complete different pathway for how to process the tissue.
Right.
So from my understanding, there's a lot of gap of communication from the radiologist.
You're
to the
right.
pathologist.
You're right.
So how can you fulfill this gap? One of the ways is to do pathological radiological correlation regularly.
Yes.
That kind of fulfills the gap. Number two is, if as a pathologist, if I know from the very start this is a B3 and B4 lesion.
Yes.
I will treat that specimen completely separately.
Right.
See, what happens is majority of the times, every single biopsy is just coming in as one formalin, and I just gonna embed it,
Right.
and I don't have a lot of information. So in our hospital, we have for B3 and B4 lesions a complete separate pathway.
Right.
We X-ray them, the radiologist mark the area, worrisome.
Yes.
When I get the specimen, I actually look at the specimen and look at the X-ray.
But is it B3 not it's not a radiological? I can write B by it's 4, but
Yeah.
B3 comes after biopsy to us.
Yeah, I understand, but even when you have a good correlation for the pathology
Yes.
radiology findings, so what we in our EMR system, we actually included a separate in the pathology report that is between the radiologist and the pathologist.
Yes.
And the radiologist is writing its comments is not medical legal because
Right.
it's just communication.
Communication.
So like it's a
Yes.
comment. It's not going to go into the report, so you're
Yes.
medically very safe.
Right.
So you are able to express a lot of things
Yes.
to the pathologist
Yeah.
that usually you're not.
Yeah.
It's very difficult to just pick up the phone and call and
Right.
everything like that.
Right.
So I realized just that communication
It,
and then doing the radiology, pathology correlation
yes.
really makes
It
a lot
really
of
helps.
difference.
Yeah.
A lot
So
makes
we do send the ultrasound images.
ultrasound images.
Mammogram, they say we can't read. For us,
Okay.
all calcification, unless you show us calcifications in the sample, that is where I take X-ray of the sample and send.
That's excellent.
Because
So
sometimes what happens, what our pathologists have told us, very small calcification too, sometimes a sink at the bottom.
yes.
We may not have calcification can come separate, tissue is separate in stereotactic. If it sinks and only calcification has atypia, it may be missed.
Exactly.
Then what you do? So that is where MRI, IC enhancement, then we do open excision. That is the only thing.
So
we
for
can.
calcification, what we do is we already know when the specimen comes into the lab, we already know this has calcification.
Right.
So even the technologists know that this has calcification.
Right.
Do not waste any tissue. They're gonna cut 10 blocks.
Everything. Right.
Okay. And then next morning I have the slides. I don't see calcification. Immediately send the block for X-ray.
Right.
I don't go and waste my time.
Absolutely.
I just send the block for X-ray. Come back. The marking area. This is the calcification. I waste the block. Complete
Right.
cut. Then I have calcification. It's really 2 days turnaround time.
That's
It will
excellent.
take me 1 week of work up.
Yes.
It's just the proper pathway. It really makes a
Right.
lot.
No, that's very insightful. I will definitely try to incorporate more in our practice about this.
Wonderful. Great.
Thank you. Thank you. This again.
Anyone have any questions? If you don't, thank you. Your nice talk.
Thank you.
The certificate.
Yes, thank you.
Yes.
You change the display. I think display was changed. You need to duplicate the display. Okay. It's me again, sorry. I'm sure everyone is fed up looking at my face. But now we have a wonderful speaker, Dr. Ibrahim. We know that he is a wonderful speaker and he'll engage everybody with his talk. Thank you, Dr. Ibrahim.
Thank you so much, everyone. And this is my last talk, so you guys are not going to see me anymore. And okay, so slides. Yes. So this talk, it just worked out so nice that I give the cloud talk first, because really the cloud is about computing and how AI works and the computing power and the storage power and everything. And now we're going to the AI talk of it. So I'm going to talk about basically what is AI in pathology. So, artificial intelligence is really creeping into everything, and we are moving from wet, sophisticated technology testing, wet lab, to statistical models. And we have many examples. Oncotype DX, you just name many, many oncological testing. So almost any, we're moving from wet lab, sophisticated technology to statistical modeling. And a lot of times the statistical modeling is way better when you're doing NGS, proteomics, just any omics you want to do. When you go to the statistical modeling, sometimes you're able to get a much better results. So how the first thing is, we as a physicians, a lot of times we are very skeptical of this. We think of AI is going to take over the world. There's going to be missiles coming in from everywhere, and humanity is going to be destroyed. This is what everybody thinks of AI. So I really want to tell you, what is AI? It is not about taking over the human beings. No, it's not about, when I give a talk on AI, the first thing people come, when do you think I'm going to lose my job? You're never going to lose your job. You're never going to lose your job. You really need to understand AI is nothing, is literally nothing. So I'm going to show you what AI, if you look at an image, it's a small biopsy image of a histology slide. And if you look at it, how does AI looks at it? What it does, it actually converts it into pixel grades. It depends on the image. So in radiology, we have very amazing, because it's only one pixel grade grayscale. So each pixel has a different intensity. So it will give you a pixel grade, and the radiology images are not that big. So they are like 2000 by 2500 X-ray, and the MRI scans and CT scans are 512 by 512 each slice. Okay, but you have hundreds of slices, but there's only one pixel grade, one matrix pixel grading. Okay, in pathology, is a little bit more complicated because we have colors. And we have colors, we have three different grids. We have one for red, one for green, one for blue. We call it RGB grids. Okay. So technically speaking, it's kind of more computing. It requires a lot of computing power, because you have for each image three grids. So if I have one whole slide image, if it's 100,000 by 100,000 pixels, then I have red 100,000 by 100,000, blue 100,000 by 100,000, green 100,000. So I have 300,000 by 3 billion information pieces that AI has to calculate. So you understand that if you want to do the computing on a colored image, you need cloud. You cannot do with a regular PC. It's just impossible. So this is how, just to give you, AI is not doing anything. It's just a mathematical modeling of how to make patterns in databases. And AI is very good in this. And we have built, artificial intelligence is actually very old. In 1940s and 50s, the first algorithms were built. Basic algorithms were built in 1450s. Then in 60s, we have distributed systems coming in. Basic cloud systems come in 60s. The first guy who actually started working on it. But the problem was there was no computing power. And everybody got stuck. No computing power. You have the whole concepts. You have the statistical models. You can do a lot of things. But number one, there's no data because you require storage. And number two, there's no computing power. So AI got stuck. But now cloud came in 2014, 2012, 13, 14. Computing power came, storage came. And that's why you're seeing in the next 5 to 10 years, revolutions will happen. And the core of it is cloud. Cloud is providing you the computing power and the storage that is needed. So majority of the AI models, whatever AI model you're looking at, there is a ground truth. This is the set of training data. You classify an image. You are a pathologist, you are a clinician, you are anything. You set of images, you classify them. This is benign, this is malignant, this is atypical. You classify images into a bunch of categories, okay? And you ask the computer, this is the ground truth. And then you ask to run a neural network model on it. And what we'll do is, it will take an input of a testing case that is not included in the training data. It will take a testing case, it will process it through neural networks. What is a neural network? Neural network actually breaks down the images into multiple processes, small process. Each layer does focus on one specific thing. Say, if you teach the computer on a bunch of images, this is cat, this is dog, this is cat, this is dog. What will do, the first neural image will only highlight the edges. The second will show pointy ends. Second, they just keep going, and then they will compare to the ground truth. And they say, no, this is not working, go back. Then they process more, and they go Ground truth. No, it's not working. Go back. Until, and every time they're going back, they're decreasing the weight of certain parameters, increasing the weight of certain parameters. They're basically balancing the formula. It sounds mathematical, but it is immense computation that we cannot give a number to it. It is basic statistics, but to an nth degree. So just to give you, this is an image, a biopsy. It goes through the neural network. There are some basic features. The first layers of neural network would be just looking at the identifying edges, lines, textures, boundaries, just basic things. The intermediate layers will be looking at patterns like texture, clustering, spatial features. Advanced focuses on like finding this is the nuclei, this is the cytoplasmic. And the deeper layers will actually be looking into spatial contexts. So it is complex, but it's the same thing that you do when you look at an image. When I look at a person, I know who's this person. Why? I don't do the calculations of the nose and eyes and everything. No, it's just inherently you do it. I know this person. His name is this. How do you come up with it? There is some calculation happening in your brain, and that's exactly the same happening in neural network. Okay. So I had a discussion about head and neck tumor. I was a fellow in 2006. And if you look at, there's a very common scenario among the cytologists. We've been practicing cytology from 17th century. Some cytopathologists say, I can differentiate follicular adenoma from parathyroid adenoma. I can differentiate. And then you give them the cases, they fail. So I was training at Yale, and I had a spectral imager. A spectral image is a computational image that not only looks at the visual, and this is one of the solutions of interoperability, that you expand your visible light to invisible light. Because there is a lot of information in the invisible light that I cannot see. And that's what AI does. It is able to perceive things that you cannot perceive. So what I did was I actually attached a microscope, which is a spectral microscope. It takes the full spectrum of the light, invisible and visible. And I had 25 cases. I had a lot of cases of follicular adenomas, but I had very few cases of parathyroid adenomas on FNA. So I trained on 5 cases of parathyroid adenoma and a bunch of cases of follicular adenomas on a cytology slice. And this is published in 2007. AI, this is 20 years old stuff on cytology. I was lucky in the sense that I had spectral information. So I had richer information. If I was just using the visible light, I might not be able to get the same results. The more richer the data you have, the more you're able to find patterns. So my data was very rich because I had the invisible light and the visible light. And we did the comparison, and you will be shocked. Almost 100%. 98.9, 90 sensitivity, specificity. The computer was able to detect parathyroid adenoma from follicular adenoma 100% on cytology images. So to give you an example, so how do we, that's what I'm saying, anybody can do AIs. And now you don't need a coding as well. There are amazing tools available that you can actually learn and use them to annotate data. One of the biggest problems in AI, in pathology, is data. We have not been, radiology is very lucky. They have been digitizing their images from really long time, 10 and 15 years now. So they have a lot of data. We just started digitizing less than 5 years ago. We don't have data. Number two, the data is so rich, I don't have computational power. Even with the cloud right now, I don't have the computational power to run billion pixels for each image. I don't have the computational power. So what you do is, how do you solve this issue? There are different ways of doing machine learning in pathology. You do the standard machine learning by basically extracting features yourself. So what I did, I extracted the nuclei and the cytoplasm of each cell myself. I did not throw the whole slide in there and say, figure out which is done. No, I extracted the features myself. Physically, I extract. This is a parathyroid cell. This is a follicular cell. This is a parathyroid cell. This is a follicular cell. This is a basic machine learning. You can have basic machine learning. You don't need that much of deep neural network in it. You can have 1 or 2 neural networks. But if you want to put the whole slide and ask the computer to extract data, that needs a deep neural network. It needs more computation power. So one of the ways of doing it that everybody can do pathology by computational power is doing standard annotation. One of the biggest things we are missing right now is we don't have annotated slides. So we can learn models on it. Okay. The second model is convolutional neural networks. Convolutional neural networks, what you do is you actually do not run the whole pixel by pixel. You ask the area that I'm only interested in this area. This is the malignant area. The rest is benign. So now the computer knows that I don't have to run the entire pixel by pixel. I just have to focus on that one area. So you can do convolutional network two ways, either pixel by pixel, or there's a technology which is called multiple instance learning. Instead of breaking pixel by pixel computation, it actually breaks the area of interest into small patches, 100 by 100 pixel patches. And then it does algorithms on it, and then it finds patterns in it. It decreases my computational power. It increases my efficiency to do learning. So this is a basic concept of what is AI in pathology, okay? Now, the ground truth could be, this is ductal carcinoma, this is lobular carcinoma, this is this, and it will predict everything. Or it could be survival data. This lesion, survival is 2.5 years. This region, survival is 1.5 years. This lesion survival, it will predict from the morphology survival. Or it could be molecular and genomic data. You can say this lesion is ER positive, this lesion is PR positive, this lesion is HER2 positive. It will predict the whole thing for you because we have rich data. Can anybody predict? I know as a pathologist been practicing looking at the breast cancers, I know this is ER positive cancer. I know that just from looking at it, this is ER positive. But I cannot tell you, I cannot. I'm 80%, maybe 70%, depending on my experience. But the computer goes beyond human perception and is able to predict 90, 95%, even molecular markers from basic images. Okay. Now, this is what we did, machine learning, individual level, one neural network at a time. What else can you do? You can actually decrease your computational power, increase your accuracy by creating multiple models. Like in breast, we do breast scoring, grading. We have nuclear atypia, we have glandular tubular formation, mitotic activity. Instead of training the breast cancer, this is grade 1, this is grade 2, no. I create a separate model for each. This is nuclear atypia 1, this is nuclear atypia 2. I decrease my computational power, increase my accuracy. This is what multi-modeling does. The multi-modeling actually increases your accuracy, decreases your computational capacity. So now this is up to now, we are the basic stuff what AI can do for you. Now this is high end. Okay, this is not a normal pathologist can do, and normal institutions cannot do. These are your organizations who are focused on research and they're doing on these. These are called weekly supervised learning. Weekly supervised learnings are basically you do not have time to annotate the data. You don't have any time. The only thing you have is that this slide is a colorectal cancer. That's the only information I have. I cannot annotate the data. I don't have time for it. I have a bunch of slides. I know that this is colorectal cancer. This is squamous cell carcinoma. This is one. So there are groups. This one group that I'm talking about is from Harvard group. They're really doing amazing pipeline of modeling, which is compatible with our time. Right now, we have digitalized slides in institutions that have digitalized slides. They don't have no annotation. The only thing they have is the diagnosis. Slide level diagnosis only. So you have two different techniques of doing it. You can do graph neural network. A very interesting approach of doing neural network. What you do is you extract each nuclei from the images, and then from that each nuclei, you actually extract features of the nuclei. And then you get the spatial features. It talks about how far is the each nucleus from each other. These are spatial oriented nature. And it will build a graph on the tissue. And I'll show you some images of that. The other is multiple instance learning that I already said. It breaks down the tissue into multiple small bags, and then it does different things. So one of the best pipeline that have built so far is you do a combination of modeling. Number one, you do clustering. You do multiple instance clustering by breaking down instead of pixel level. You do patches. Then these patches are clustered into attention areas. And then, so I'm going to show you an example. This is how exactly this pipeline is working. It takes all the clusters from that image, it scores it. It gives a different branch scoring, and then it self-supervises different clusters into different seeds. And then it extracts features from it. Now, again, this is a very complex, high-end research level only. Modeling that is called pipeline of modeling. Many models are working at the same time on image that is extracting features from the image and doing things. Now, what they did was they actually took this pipeline and they implemented that on renal cell carcinoma, non-small cell carcinomas, and metastatic lesions of breast. They were able to get 95% accuracies. They were able to classify all type of renal cell carcinomas, extracting from resection slides. Now, we're talking about interoperability, okay? So Not only that, they take the same model and they run it on biopsies. See, the model was trained on resection specimens, huge, big tissues. They took the same model and they run on biopsies, core biopsies. They were still able to get 0.9% above AUCs, more than 90% accuracies. Even interesting, they took the same model, and for low resource countries like Africa, they were trying to build this model. They take pathologists can take an image, like the technician can take the image from this microscope slide, and they run that image on the model, and the model was able to give the diagnosis. You train the model on resection, it run equally good on biopsies, and now you're taking picture from photo and it's giving you the diagnosis. This is interoperability of the model. This is how things are moving, okay? The same group actually worked on pathology cases of cancer of unknown origin. It's a very common scenario. 3% of the cancers are cancers of unknown origin, extensively worked up MRI, immunohistochemistry, molecular markers, everything. They trained on around 2,800 cases, 18 different cancers. Look at the predictability. Look at the, I don't have the, this is the accuracies for each organ system. Okay, 0.8, 0.9, 0.8. There's some were very low. They were able to do very good just on images. They trained on around 700 to 800 images, but they were able to predict the tumor of unknown origin. Not only the tumor of unknown, they will tell you that this is a primary or metastasis as well. They were able to tell if this is primary or metastasis. Okay, so again, this is just to show you that how they were able to use the same modeling on different kind of specimens and were able to do that. Now, the second thing that I mentioned, you guys, was graph neural network. Again, a model requires less computational power. What you do in it, you extract all the nuclei, and now you can do it, either you do it manually or there's models who actually extract the nuclei for you. And each node is actually represents the nuclei. And you can see each node has multiple layers. It actually stores a lot of information about the nucleus, about the texture, about the boundaries, and then it gets the spatial information. We didn't know as a human being that actually a lot of the molecular markers that we see are spatially oriented. ERPR is spatial. IDH is spatial. We think of it as a physical thing, but we didn't know that there is something about the nuclear distance that tells us the molecular markers. So they did that. They actually, this is just to show you, this is a benign colon, and this is the graph of the colon. This is a adenocarcinoma of the colon, and this is the graph of the adenocarcinoma of the colon. Very different. Now, what they did was they actually used graph neural network to see, can it predict? So this is gliomas, IDH mutation versus not mutated. 0.9% accuracy. 0.9% accuracy, just from graph neural network. Now we have a study right now, this coming in very size under research. You can do through MRI. Through MRI scan, you can actually predict the IDH mutation from the MRI scan of the brain gliomas. Now, they were able to predict ERPR status, 0.85%, which is pretty accurate for a low resource setting, which very difficult to get immunohistochemistry. You can actually predict just from the images, is this ERPR stored? Now, this is the ultimate thing. You take convolutional neural network, the patches and the physical information and the edges and the graphs and everything. You take the graphical neural network, you take the spatial information of each nucleus, how far it is, and then you merge it with the genomic data. And this is what is happening right now. Tensor fusion is how you're merging different models to predict almost anything in new morphologies, risk stratifications, the therapeutic response. Like, you cannot imagine things that the model is able to predict. Biomarkers, new inventions, they are coming in from these models. So I think just to show you this is a graph. This is the Pathomic fusion model, was able to detect the gliomas even better than molecular subtyping by 0.631%, better than molecular subtyping. Right now in gliomas, the best classification is molecular classification. The Pathomic fusion was able to classify the tumors even better than that. And this is the future. The future is you get the phenotypic data, morphological phenotypic data, then you get the spatial analysis, spatial information, and then you include the genomics and omics and the molecular markers, and you fuse them together and you predict. Now, this is all future. It is happening, but this is what's going to happen in 5 to 10 years. You will be able to predict things that you cannot. So this is about this histopathology. I'm going to just briefly touch on what is clinical pathology doing it. You know, everybody know of MALDI-TOF? Mass spec, everybody knows mass spec, isn't it? Mass spec is you put the chemical and it creates a fingerprint for you. So in microbiology, you can actually take my bacterial colony and you put it in a spectrum, put a laser, and it creates spikes of each protein that comes out of it. This is the mass spec. We use the big peaks to identify organisms in mass spec. It's very fast. We can get the identification within a few minutes. Now you put AI on it. You are able to detect antibiotic resistance. You are able to detect a strain level identification. You are able to detect if the bacteria is under stress or not, if the bacteria is going to go and have resistance or not. You can predict a lot of information. So I think just to give you just to brief, you look at the peripheral blood smears. Everybody do peripheral blood smears. This group actually trained a model on patients who were cancer patients coming in and detect what is the mortality rate for this patient. The model looked at very variable things. The RBC morphology change. We look at it, we say, yeah, there are few schistocytes, few abnormal red blood cells. But the model was able to predict exactly what is the percentage, how many schistocytes, how many smudge cells, and they were able to predict the mortality of this case. Very accurate. So diabetes, I'm not going to it. Every single area of diabetes is affected by AI. AI has from sensors to people who are wearing these devices. You just go into diabetes, patient engagement is there, many tools are there, and there are many devices now approved from FDA for diabetes prevention. AI is big into chronic diseases. This is clinical pathology. And then you have autoimmune diseases that you can actually predict autoimmune diseases from the basic markers. You can predict liver fibrosis from basic liver function tests. So many products are coming. So I don't think so I can cover the entire AI in pathology because we in pathology are a little bit advantaged because we have rich data. And this is the best for AI. AI works on rich data. So we are really privileged in that sense that as a pathologist, as the people who work in the lab, you really have the gold mine that the AI will build on. So I think you should feel proud of that, although we are at the start right now, but this is how the future is going to be. Thank you so much.
Excellent talk, Dr. Imran. I am a radiologist, but I am tempted to at least put my son into pathology now. I'm telling you, it is very interesting. Thank you. So I was excited to hear this. I'm sure every radiologist and the budding radiologists are definitely going to be happy that you presented this talk and would like to explore this further.
Appreciate it. If you guys are interested, I do talk a lot on LinkedIn on AI and solutions. Connect with me, and it will be good experience for you guys.
I'm sure it's going to be an excellent experience. Thank you.
Any questions, please? Yes. Can you get the mic over?
I have a lot of my name is Tahir Rawat. I'm a hematologist and molecular pathologist from Belgium.
Very nice. Very
nice. Very exciting and very interesting presentation. And that has been one of the main reasons actually I'm here today.
Excellent.
So I enjoyed very much and thank you for taking us from your past to our future. I believe that's a great, the knowledge of knowing what's coming for all of us.
Exactly.
And as you mentioned about the correlation between genomic and also AI-based image analysis. So recently, I have seen some publication, as you mentioned, that has been many publications indicating the correlation between expression of genomic as well as how far do you think that we can go on this matter and how we should use it exactly? And currently, what is the current state that still we do genomics, still we also on the side we use to this AI, but how we should, apply to this our practice.
So predicting genomic data from the images only has reached to 0.85% AUC, area under curve 0.85, 0.9 maximum. So it is not still 100%, but it is really amazing in low resource areas. If you are in a country where you have very difficulty of getting immunohistochemistries or molecular markers, it is miraculous. 0.85% accuracy. That you're getting 85% accuracy on that. So, but in resource-rich countries, the goal is still to continue working with all the molecular workup. And ultimately, what's going to happen? There are groups who are working on this data, on extracting the molecular information from the images. So many groups are working on it, and as the matter of time, and I'm telling you, it is not the fault is not with the AI. The fault is ours that we don't have data. Give it time, give it some time, give it a few years, and then once you have the data and once you have the right models, I am telling you, just like Oncotype DX, just like molecular testing markers that are predicting the behavior of the tumor and the immunological markers, you will be able to get a molecular profile just from the images. Very soon, I'm telling you. And I'm telling you, even I'll tell you, less than 5 years. A product will be available.
Just I would like also share one of my experiences that how important I believe your comments are in this aspect. So recently we had a case of glioma, and it was negative for IDH1 by genomic. And the reason because that was very low coverage, very noisy area, and we missed that on bioinformatics analysis. And later it came up to be a positive biochemistry. We received almost 2 weeks after. That was the kind of really discussion came up that how anyway I believe syncs is going to be very important factor on that aspect.
Totally agree with you. This is exactly what is the future moving in direction. Yes.
I have one question.
Please.
Dr. Khan. I'm not sure this is related. We do thyroid FNAs, follicular atypia. There are 4 to 6 follicular. I know that more than 6 is required for classification. Now, is there a scope? We do a Pharma test, which is follicular imaging. How much is the scope with AI in that so that the patient gets minimally invasive and then we know because a Pharma, it goes to US, it is not done in UAE and it takes
So
20 days.
overall, I'm going to tell you, the majority of the work that is happening on AI is happening on the architecture, on the tissue. Very few work, literally a very few group of people are working on cytology for AI solutions. So I don't see that as happening very soon. Very few group because the spectral imaging that I was able to get, this is from NASA. I was able to get an access to it because I was at Yale University and NASA was able to give me this technology that very difficult to get it. And I was able to grab information that is very rich. Right now, we as pathologists who have basic information, we're only going to get just the visible light. And we have problems with visible light. If the immunohistochemistry, if the ESN is slightly higher, then the AI is going to mess up. So I don't see that happening in future. That's something that is going to take time. But structural, that I take graphical neural network, neural distances, multiple instance learning, clustering, pooling, that's going to come very soon. Yeah.
Thank you.
Yep.
So our next speaker is Dr. Kunda. He's the keynote speaker and he would be introducing himself. He is presenting a talk on SVT and novel nucleoside as effective treatment for HIV and COVID-19 infections. Thank you.
So, can someone help with the slides? Okay, thanks for the conference for giving me the chance to share our work with you today. I quickly discovered I might be the only discovery person in this room. A lot of clinicians So what I'm about to present may not resonate with you in terms of details, but I just wanted to share this story that this compound we discovered for COVID-19 during the pandemic. Really, my purpose here today is to try to introduce the Chinese pharmaceutical discovery industries to this region of people, and with the hope that we can stimulate collaborations in all categories in terms of both basic research, clinical research, and perhaps even some investment chances that we can consider. So a quick introduction for myself. I got my PhD in Purdue University in United States, and I work in the States for about 30 years. Some biotech experience, Lilly and Merck. In 2018, I returned to China, joined a couple of Chinese pharmaceutical companies, and now I'm currently the president of Genuine Biotech, a small biotech company in China. So the story I'm about to tell you today is a nucleoside, a small molecule that originally discovered to treat HIV infections. And during the pandemic, we discovered that this compound was exquisitely effective against the COVID-19 virus. And later on, we discovered that this molecule, this wonderful small molecule, actually has potential to treat cancer, and especially liver cancer. And today, I'll share with you some of the data that we generated. Okay, so we all know the pandemic of COVID-19, and it's important to treat the infections early on, and the sooner you can get on with the treatment, that the virus can be controlled effectively. Once the infection is fully blown, it gets deep into your lung, then it becomes more difficult to treat. It's not just a simple case of viral infections. There are three main categories of drugs to treat COVID-19 infections. The first, the protease inhibitors. The most famous is the Pfizer compound, the Paxlovid. Then there's this nucleoside type of compound that's exemplified by Monoprovir. So this is a compound developed by my old employer, Merck, which actually is based on the first generation compound, the Remdesivir, which was discovered by Gilead. But that compound has to be given IV, and Monoprovir is oral treatment, which is much more convenient. And the third class really is the antibodies. So we all know in the beginning of the pandemic, a lot of antibodies were discovered, and it was very effective. However, the problem with antibodies is that they're too specific. And as the virus mutates quickly, the antibodies quickly become ineffective. So, which left it mainly with two class of compound to treat infections. One is the protease inhibitor, the other one is the RDRP polymerase inhibitors. The RDRP inhibitors are mechanistically it's very simple. It's a nucleoside that the virus cannot differentiate from the natural substrates. So they have to replicate, and they incorporate these nucleoside analogs into the chain of events. But once the nucleoside inhibitor gets incorporated into the chain, it cannot propagate. It terminates once it gets into the RNA chain, which we call a chain terminating inhibition. And both Monoprovir and our compound belong to the same mechanism. So our molecule, like I said, was originally discovered to treat HIV infections, and as a nucleoside, it's a well-known MOA to treat HIV infection. And so we started a phase one trials in China, and with a rising multiple dose, and the compound was well tolerated. And then we did a multiple dosing, 2, 3, 4 milligrams QD, so one dose per day. That was also well tolerated. The compound has excellent safety profiles. Then we did a phase 2 trials in HIV, and it was effective and it was approved to treat HIV infections based on the phase 2 data. When COVID-19 happened, the pandemic, we quickly started 3 trials, and one in China, one in Russia, one in Brazil. And with the 3 trials, we are targeting different populations. So total is about 1,000 patients was treated with this compound. The compound was given 5 milligrams per day QD for 14 days. And we were looking at 3 different side of category of markers. One is to look at the viral load change, reduction of the viral load. The other 2 trials we were looking at the clinical symptoms improvements, and also the hospitalization time reduction. So I'm just going to present a quick summary of our Russian trial. So in this trial, there are 314 patients was enrolled. It was split 1-to-1, treating with our compound. So here's the baseline characteristics. I'm going to quickly go through these because I have some more, I think, more exciting data in the end. So looking at improvements in clinical status, so these are scores that we calculated based on the WHO criteria. So they based on the clinical symptoms, you gave a score, and looking at the treatment groups, the p-value, no matter you look at the FAS way of looking at things or PPS, the difference between treated and untreated groups are quite significant. The p-value is less than 0.001. So very significant difference between the 2 groups. So this is looking at another way of looking at the different treatment groups. The azuvudine treated groups is significantly improved compared to the placebo treated group. This is looking at the time for hospitalization. As you can see, the untreated control group, the average is 13 days. And in our case, the average is 10 days. So there's a significant difference. In terms of safety, tolerability, like I said in the beginning, that we in our phase 2 HIV trials, we dosed 600 patients for 48 weeks. There's no safety, no treatment-related safety signs with this compound because the dose is very low. For the HIV trial, we were giving the patients 3 milligrams QD, so very low dose. And so this is not surprising to see in the Russian trial, the tolerability is extremely well tolerated. So in conclusion, that through the Russian trial, we find that the FNC treatment significantly lowered the viral load and significantly improved the clinical symptoms and shortening the hospital stay. And thirdly, the compound's well tolerated in this trial. And so based on the three phase 3 trials that we conducted in China, Russia, and Brazil, this compound was approved in China in August of 2022. So this was the first small molecule approved in China in terms of oral treatment for COVID-19 infections. The structure of the compound is shown on this slide. But if you're not a chemist, you probably don't appreciate the structure. So this compound, when it's approved, we were pricing it at a level of significantly lower than the Pfizer compound. So in 2022, the Pfizer protease inhibitor Paxlovid in China costs 2,000 RMB per therapeutic per therapy, and our compound was priced at pricing at 300 RMB. So in terms of patient access, so there's a significant number of Chinese patients can afford this compound, and the Pfizer compound, because it was priced so high, a lot of the remote area of China, the Chinese patients, they cannot afford, and then they cannot access the Pfizer compound. So as a result, when the control of the pandemic was lifted towards the end of 2022, our compound has been given to more than 10 million Chinese patients infected with COVID-19. So we did a lot of real-world data analysis. So this is during the lifting of the treatment. I'm giving a couple of examples here. One, this is in a 1,000 hospital, Xiangya Hospital in China. So from December of 2022 to January of 2023, so 2 months, when the nationwide control was lifted, a lot of people got COVID-19. And we're looking at 15,000 hospitalized patients with symptoms. So these are older patients with the average age of 65 years old. And about 65% with serious symptoms. About 80% of the patients, they have other diseases, comorbidities. So in the end, we were looking at FNC, so azuridine versus placebo, looking at the reduction of death. So the reduction of death compared to placebo, giving our compound is 74%. So it's quite significant. It's on par with Paxlovid in terms of with serious infected patients. And so this is another analysis of the Shanghai region. So a lot of people in Shanghai, there are 20 million people in Shanghai. So this is also analyzing during the same a period of time towards the end of 2022 and January of 2023. And this is looking at about 1,000 serious patients, it's critically ill patients with average age of 78 years of age. Because these patients are older and their other diseases are more serious. And so during this 2-month period, about 139 patients died within 60 days. And in this study, we were looking at a head-to-head comparison of azuridine versus Paxlovid in terms of 2-month OS, overall survival. So patients treated with Paxlovid, the 2-month survival in terms of protection is about 91.9%. Giving our compound is 99.8%. So there's only 1 patient died in our treatment group. So in terms of both overall death and also seriously ill patient death. And our compound it was shown extremely effective. And like I said, more than 10 million people have taken the drug, and so far we have not heard any treatment-related side effects. So in terms of tolerability, the compound is very safe. And since the approval of this compound as a treatment of COVID-19, we have further expand indication of this compound to treat cancer. As a researcher, so my background is primarily in early discovery, and we know nucleosides like gemcitabine, capecitabine, these type of nucleoside drugs, they have very potent anti-cancer activities. So we're looking at our compound also in this liver cancer model. Let me walk you through this study. So this is looking at azuvidine combo with PD-1 antibody in liver cancer. So black is the vehicle-treated group. The light pink is low dose with azuvidine. You can see the tumor inhibition is somewhat is moderate. But in the higher dose, 1 mg per kg dose, which is the red triangle, you can see the tumor was very well controlled. And towards the end of the study, towards the end of the dosing, so the dosing was given 27 days. Then the drug was off, and then we observed these mice for 100 days. And as you can see, by towards 40 days, about 38, 37 days, some of the mice actually complete cured. The tumor complete disappeared. Then we compare with the antibody, right? Just the antibody, which is the light blue color. You can see it controls the tumor well, but eventually it will rebound. Towards the end, once you take off the drug, the tumor will regrow. However, the green triangle is the combo group. You can see by 38, 37 days, all the mice were cured. So 10 out of 10 mice, no more tumor. And what's even more amazing is that these tumors, they don't grow back. Unlike these monotherapies, right? Both azuvidine and PD-1 antibody, the tumor regrow. But the green, it stays flat. And so we're very happy to see up to 100 days, these tumors don't grow back for these mice. And the mice treatment is 100% CR. So 10 out of 10 mice is cured. Then we did a similar study looking at other tumors. So maybe this was just a specific case with a liver cancer model. So this case, we look at this CT26 model. So this is a colon cancer model. And basically, similar results, right? So the blue combo group complete cured the mice after 39 days. But we did one more thing in this study. So we took the mice that the tumor complete regression, then we re-inject the mice with the tumor and to see whether the tumor can regrow. And in this case, none of the mice, the re-challenge study, none of the mice regrow the tumor, which tells us that the azuvidine PD-1 combo has a immune memory. So the mice immune system recognize the cancerous cells, right? So it's almost like a vaccine. So it prevents the this type of cancer regrow in this system. So we're currently looking at the mechanism, right, of FNC as a cancer treatment potential. And so you probably wonder, so you have an antiviral compound, why is this effective against cancer? So it turns out we did a monkey study during the COVID-19 treatment period. And we discovered that FNC can serve as a immune modulating agent. In this case, giving FNC treatment, we discovered that the CD4 and CD8 positive cells can increase up to 30%. So this explains why FNC combo with PD-1 is more effective. As you know, PD-1 anti-tumor activity is due to T cell killing of the tumor cells. And because of giving FNC increased the number of T cells by 30%, and therefore we are boosting PD-1's anti-tumor activity through immune modulating activity. So that's the MOA of our compound for anti-tumor treatment. So in summary, I have shown you today FNC has a broad antiviral activity. It was first approved in China in 2021 to treat HIV infections. Then in 2022, it was approved for COVID-19 infections. Now, currently, we're developing this compound as a part of a once a week oral treatment of HIV, which will be the first in the world. As you know, most HIV treatment is once a day. So we have two compounds that has long half-life. We can do a once a week oral dosing treatment. We're also working with a British company to develop a long COVID therapy. That's about 10-20% of patients infected with COVID will develop a long-term illness. We're developing a combo therapy for that. And finally, we're developing FNC as a immune modulator to treat various cancer. We have since started several IIT studies in patients, and I'm happy to report that when we combo with PD-1 in the last line patients, we have saw 5 cases of PR. Some of the tumors have shrink by more than 50%, like gastric cancer, liver cancer, lung cancer, and colon cancer. So this not only we see the activity in animal models, but we also translate it into humans. And so, like I said in the beginning, the purpose for me being here today, one is to introduce to you our wonderful compound. It has antiviral activity, it has anti-tumor potential, but also, as many of you know, that a lot of multinational companies are going to China to license new drug candidates, like ADC type of product to treat cancer. I just want to let you know that there's many new drug discovery companies in China with many different new medicines on the horizon, and we definitely welcome any form of collaboration. And I do believe in healthcare, in treating patients, there should not be a boundary of countries. I think the world should collaborate together so that our patients can have access to the best medicine at an affordable price. That's the goal of our work. Anyway, my email's on the slide. Anybody have interest in any way form of collaboration is highly welcome. Thank you very much.
Thank you, Dr. Kern. Just one question. I have two questions. When you were classifying the patients and their risks for mild, moderate, severe, what criteria of classification in COVID disease?
Yeah, so that there's a guideline from the WHO, right? And I think when you see images of the lung with infections, that's considered serious. If it's just cough or fever, that's less light symptom. So if it requires hospitalization, then that's a serious infection.
It was not the viral load or anything, it is more of imaging and the symptoms.
Yeah.
And secondly, comparing the results of the Pfizer based in your company. So were comorbidities taken into account for the because that medicine had 91% mortality and yours are 99.8. So in that case, did you include comorbidities and things like that?
Yeah, very good question. So the Pfizer compound, if you're familiar with the case, it's a dual drug. It has two drugs that's in one pill. One is the protease inhibitor, but the compound has very bad PK. So the body metabolizes the compound very quickly. So they has to add a second drug to inhibit a metabolizing enzyme in the body. It's the CYP3A4 inhibitor. Because this CYP4 inhibitor can affect other drugs like diabetes, like cardiovascular disease, right? So if you take statin, if you take um, blood sugar lowering drugs, if you take Pfizer's compound, high likelihood you will have a DDI. Our compound doesn't have that case. Very clean, very safe, right? So the mortality rate difference, my guess is to some extent related to.
I have a couple of questions.
Yeah.
Regarding that, you mentioned Jivudin usually elevate CD3 percentage and CD4, CD8 percentage. So is it there any steam pathway or interferon gamma pathway that is elevated? I'm just guessing whether that pathway will be affected by Azimutin.
Yeah, very good question. I'm glad there are basic research related scientists in the field. So the MOA for increasing T cells is actually related to MDSC. So the myeloid suppressing cells actually inhibits T cell proliferation. It turns out our compound can lower MDSC quite a bit by 40 to 50%. So our belief is that the compounds increasing T cells is not a direct effect on T cells, but rather inhibition of this MDSC cell, which controls the T cell.
Is there any scope in future, because we are right now facing giving PD-1 inhibitor immune-related adverse event. So is there any scope in future to go for antibody drug conjugations, means involving PD-1 and IgG?
Yeah, so like I said, the immune modulating activity of this compound means that it has potential to be comboed with other IO treatments, right? It doesn't have to be PD-1. It can be TIGIT, it can be LAG-3, it can be ADC related compounds, right? But this we have to like work out each combo as a therapy, and as a small company, we have limited resources, right? Limited the budget to do the studies, which is why I'm going around asking for collaborations, right? If any of you know of any companies that are interested in doing trials, we would be more than happy to collaborate in that field.
Definitely, actually, I work for Mr. Westwood EMS, R&D Center.
Yeah.
It is a Boston, New York based company.
Yeah, yeah,
So we are working on multiple ADC.
Oh.
So we might take this idea take forward.
Sure. I mean, we can talk afterwards. Like I said, so when I was at Lilly, I was a BD head for Asia Pacific, and I know how hard it is to discover a new drug, right? So you guys, the clinicians, you're in the front, you're treating patients. I like to say, the researchers, we gave you the weapons, right? If we don't give you the new drugs, you don't have anything to treat the patient, right? So we had to work together. Um, but as a small company, we can only work on so many things, right? Unlike even as Script, as BMS at Merck, they still had to focus, right? So I think as a collaboration, it's a win-win situation, and we both can win. In the end, the patient's going to win. So.
This would be approved in China, but what about the rest of the world for the compliance and approvals? So those things are also
Yeah.
to be put in place.
So for COVID-19, it's approved in Russia as well. I believe in Brazil, soon it will be approved. The rest of the world, I think now COVID-19 is almost past, right? And so I think for oncology use, we will have INDs in the US, in the EU. So we'll try to get approvals in outside China. So once we have the once weekly, we'll be worldwide targeting.
Because it definitely would come.
Yes, absolutely.
The audience has any questions? Okay, thank you.
Thank you.
It was very insightful. Thank you.
No,
It's still
it's a very small company, so we're not going to be China first. But eventually, oncology, they will be approved.
Creo que sí, o algo así. Aquí.
okay. So now we will be proceeding for lunch, but as I'm informed, before lunch on the ground floor, we will again have a group photo. This is a good thing. Happy to connect with everybody. Yeah, one more thing, after the lunch, we are supposed to come back here because the next session will start immediately. Thank you.
Yeah, the main thing is
Hello. Hello, good afternoon, everybody. I'm Dr. Nariman Nawar. I'm a PCP pathologist. I did my residency training in West Virginia, USA, and then I did fellowship training in bone and soft tissue in Toronto, Canada, Mount Sinai Hospital. And now I'm practicing in Saudi Arabia, which is my home country. Um, okay, can someone help me start the slideshow? Please? Slideshow, okay, from the beginning. Yeah, oh, but yeah. Hmm? Oh, okay, thank you. So my presentation is a brief presentation. Hmm? Uh, So my presentation is a brief presentation about an introduction to digital pathology. As we all know that digital pathology is really a big topic. It needs days and days of discussion, but this is just a brief introduction. I don't have anything to disclose. So what is digital pathology? So for us as pathologists, whenever we hear the term digital pathology, whole slide imaging is the first thing to come to our mind. But digital pathology is more than that. It is a discipline in which digital tools are used to advance the practice of pathology, to educate trainees, or to promote discovery. These tools include digital imaging technologies, telepathology, and data science methods such as data mining, digital image analysis, and AI. This is how it's defined by the Digital Pathology Association. Going digital or using telecommunication to provide health service is not unique to pathology. Actually, our colleagues in radiology, cardiology, and surgery had the lead in this. And there have been a dramatic improvement or need for the telemedicine in general during the COVID-19 pandemic and the period after that. Theoretically, the digital pathology as a term or the telepathology has been introduced from the 80s, and some even argues that it's been introduced before that. So why the development is so slow in digital pathology? It's not until the 2017 when the FDA approved the use of whole slide imaging for primary diagnosis. And after that, by 3 years, they approved another machine for whole slide imaging. So the idea that the development was moving slowly, and that's because of the presence of many challenges to implement digital pathology in daily practice. Some of these major challenges have been described by the FDA as lack of standardized test method that allow for correlation between technical performance and clinical performance of the whole slide imaging system. Well, what does that mean? So for us as pathologists, we are used to look at the glass slide under the microscope. I look at the glass slide under the microscope the same way my colleague look at it in another hospital. The techs prepare for us the glass slides the same way they do in Middle East, in Europe, in US. There is a well-known standardization, meaning uh, that we have certain criteria that's already standardized for the size, thickness of the glass slide, thickness of the cover slip, the H&E properties. Those are all standardized. But when we use the whole slide imaging, I might be using a different machine than what you're using. I might be scanning my slides at 20x. You might be scanning your slide at 40x. The brightness I'm using might be different than what you're using. There have been so many factors that are not standardized yet. Since the discovery of the microscope from 1600, we as a pathologist became bounded to the microscope. So by telling a pathologist, well, look, next month we will go all digitals. Well, this might not be digested by some of the pathologists. Well, what do you mean? Where do you mean that we will not use microscope anymore? Well, is the how will I trust the images coming from a machine? Is it reliable? Is it good? People tend to resist changes. Also, keep in mind that going digital is not a one-man show. You need a team to work with you. You need pathologists, you need technologists, you need the IT department, you need logistics, you need a large team. One of the main challenges is the storage. When you scan an image at 20x, you get a file as big as 3 gigabytes. If you scan the same image at 40x, you will get a file as large as 14.5 gigabyte. Well, imagine you have a big case of colon resection, then you will get a 20 slide or maybe more, depending on how many lymph nodes you retrieved from the specimen. Imagine if you scan all these at 20x or at 40x, how big the file will be. Well, does the IT infrastructure at your place support the storage of such a huge file? And keep in mind that scanner cannot scan everything. If you did an IHC on one of your cases and the stain was faded a little bit, you will be appreciate that using the microscope, but the scanner might not pick up these faded area. If you're examining a tissue from a joint and you're thinking that this might be gout or pseudogout and you're looking for crystals, those wouldn't project with the slide scanner. You wouldn't be able to use a polarizer. And in cytology or in cytopathology, we care about examining three-dimensional groups of cells. But for us, just the basic things for us, when we see 3D groups, we think cancer, we think malignancy. So we need to see or examine clusters in depth. Most scanners scan tissue at one time, and that wouldn't allow you to examine a 3D group of cells. To overcome that, one of the techniques used by scanner is called Z-stacking. That's a special technique used to overcome this issue. So you can examine 3D groups more easily. The biggest challenge is the funding. Well, those things are not cheap. To get a whole slide imaging scanner might cost $30,000 to 300,000. Well, what did I say? It might cost 50,000 to $300,000, depending on the type of the whole slide scanner, depending on how many slides it can scan at a given time. Some of these can scan up to hundreds of slides in a given time, depending on what your lab actually needs. Does your lab do a lot of skin or renal biopsies and you need to examine tissues with immunofluorescence? Then you need to get more accessories to the whole slide scanner to be able to do that. As much as you get more accessories, as much as you will pay. That's one thing. Don't forget that part of the cost is going also to the IT infrastructure, to the storage, to the personnel. You will need takes delegated to do the slide imaging, the storage, the you still have to pay for the maintenance of these softwares. So the funding is a big issue. To overcome that, some of the big hospitals choose to collaborate with colleges or research centers to overcome that. Well, does it worth to go through all the hustle to get to use digital pathology? Well, let's look at the advantages. What's the advantages of digital pathology? Why the future is about digital? Why it's a big deal? Well, for all of us as a pathologist or radiologist, we care about TAT, which is the turnaround time. Having a digital scanner or going digital can improve your TAT. It's one of the things, it's help with the interpretation of the IHC. How many of us tend to put two slides on the microscope, the H&E slide and the IHC slide, and go back and forth to see if the area of interest is picking the stains or not? I think many of us do that. Well, when it's digital, you can put the two pictures on the screen and compare it very easily, and that will save you time. Also, going digital facilitate the use of AI tools or the artificial intelligence. So instead of having KI 67 on a tumor as 20 and then your colleagues get it as 40 or something, you can get less inter-observer variability by integrating the AI tools. And one of the nightmares for pathologists is the need to do a consultation on the case. Well, doing a consultations means that the case will delay. The case will be shipped to another hospital. It will take time for the shipment. When it's shipped in there, it needs to be accessioned. It needs to be assigned to a pathologist to see it. So that process will take at least 3 to 5 days and might take longer. And going digital almost will facilitate the thing about slide retrieval and will help to avoid the thing about losing slides. Not to forget its use in education, research, collaborations. For us, we need to know pattern of diseases to be able to diagnose. But sometimes we get encounter with a very rare disease or very rare pathologic phenotype or subclassification of a disease that we might see it once in our career, or we might see it only you might see it only if you work in a big center. But if you get things stored by using slide scanners, then these materials will be available for review by many pathologists. Okay, let's say that we overcome all the challenges, we understand the advantages, and now we have our slide scanner in the lab. We are ready to use it. Well, the slide scanners is already approved by the FDA to be used. Does that mean that I don't have to do validation for it? Does that mean that it's okay? I'll just bring the company representative to train all of us to use it and then go ahead? Well, it's recommended by CAP to do a validation for the whole slide scanners to be able to use it for a primary diagnosis. And there are three main strong recommendations. The first recommendation is that the validation process should include at least 60 cases for one application. The number of cases might increase to cover additional applications such as IHC or special stains. The rationale for that recommendation is to establish trust in the diagnoses made using whole slide imaging. As we said, that pathologists for the pathologist to be able to use it, there have to be some trust. So if you do the validation on 60 cases, this might help in establishing the trust. And this will allow the pathologist to identify and mitigate risks associated with the technology. Studies showed that using more than 60 cases will not affect the outcome. The second recommendation is to establish diagnostic concordance between digital and glass slides for the same observance. The concordance should be of 95% or more. So what does that mean? That's mean if you made the diagnosis using a glass slide, will you make that same diagnosis if you use the whole slide imaging? Uh, if not, then you have to investigate why did that happen. The 95% should not be considered as pass or fail mark. If there is a case of discordance, then you have to investigate it. Does that happen because the pathologist just changed his mind on the diagnosis, or was there a technical issue and the project the scan slide wasn't as good as the glass slide? Although 100 concordance is desired, this doesn't reflect the subjective nature of pathology. The third recommendation is to have a washout period of at least 2 weeks between viewing a digital slide and glass slides. That to assure that a recall bias wouldn't happen. Uh, That's all for me. So in this talk, we covered briefly on the history of digital pathology, the challenges you might face, the advantages, and the process of validation. And thank you for having me. Any questions?
Thank you, Fatman, for your nice talk about introduction of digital pathology. Just I will give some experience from my perspective. Actually, it is an immense help that with introduction of this digital pathology, we can sometime in a post-operative setting, especially in a frozen section biopsy, where the time is very short, within 10 to 15 minutes, we have to read the diagnosis. That time we might miss the tiny focus of tumor, especially in the soft capsular sinus of the lymph node. So that time we have our in-house tissue classifier where the tumor if there will be flagging. So that can help me immensely while giving a suggestion or a diagnosis. This sentinel lymph node is positive or negative. That prospective digital pathology is a great help for that. And also another thing is that for a woman perspective, you can opt for a work from home. At the comfort of your house, you can start coding cases if you get all the history details, your crossing details, which slide is from which sections, then you can easily record at comfort of your home. So that's my views on your slides and presentations. Audience, anyone have any questions? Okay, if there is no questions, we can move on to the next speaker, that is Ms. Maria. So before that, I will give a certificate. Next speaker is Miss Maya. We can introduce about yourself.
Okay. Hello, dear colleagues, dear chairs. I'm Maria. I'm a clinical laboratory doctor and cytopathologist from Moscow Clinical Scientific Center. I'm really happy to be here today. I would like to say a lot of thanks for our organizers committee for this opportunity. And now I'm presentation. Yeah. Maybe you can help me. Oh, thank you. Okay. Thank you. And today I would like to talk with you about cytological diagnosis of peritoneal washings for the detection of free cancer cells in patients with gastric cancer. But at first, I'd like to talk a little bit about our center. Here you can see the picture, and it's our center in 2013. And now our center look absolutely very different. Now it's the biggest oncology center in the Moscow in 2024. We have 7 big departments: Central Research Institute of Gastroenterology, Institute of Intestinal Medicine, Institute of High-Tech Medicine, Women's Health Clinic, one big clinic, health care clinic on Academic Apollo, outpatient cancer care center, and rheumatology center. Now I start to talk about my topic. The choice of treatment tactics is considered according to the prevalence of the tumors stage. The microcanceromatosis of the peritoneum exam becomes one of the main problems without ascitic fluid accumulation when the process occurs with single cancer cells. In some publication, our colleague might attempt to evaluate quantitative parameters. In this work, it was more than one ring cell, more than 5 clusters, or more than 30 isolate cancer cells. The aim our work, our study was to improve the cytological diagnostics of peritoneal washings with the use of immunomorphological techniques for detection of free cancer cells of gastric cancer. Our analysis was 260 certain materials in patients with gastric cancer who were on treatment in high-tech surgery department in Moscow Clinical Scientific Center from June 2021 to March 2023. The average age was 64, including 130 women and 130 men. The peritoneal washings are obtained during the diagnostic laparoscopy. The cytological preparation are prepared by a liquid technique on cytocentrifuge cytotech. The immunocytochemical study was performed with Roche antibodies. We use automatic monocytostaining Ventana benchmark. And the following panel of monoclonal antibodies has been selected Bayer AP4 and MUC5 AC. In some cases, we use different antibodies, but it was rare cases. Here we see which characteristic we use for evaluation of the cells, the morphological characteristic. And our report has two steps. The one step we assess the presence of tumor cells, and the second step we evaluate quantitative characteristic. It's also the same characteristics: more than one ring cell, more than 5 clusters structures, or more than 53 tumor cells, isolated cells. In our study, also in 185 cases, cytological study was performed, and as a result of this study, 3 tumor cells were found in 80 patients. It was 43% of cases. In 104 patients, tumor cells were not detected in peritoneal washings, and one material was not informative. The sensitivity and specificity of this study was respectively 52% and 81%. However, accuracy of only one cytological method was 67%. This value was comparable to the general accuracy of a microscopic examination. According to the data of diagnostic laparoscopy, because it was 63%. 75 patients underwent a traditional light microscopic examination and immunocytochemical study with monoclonal antibodies BRP4 and MUC5 AC. When we use the combined use all the both methods of preparation and assessment of a material, the specificity of cytological diagnosis was 100%, and the sensitivity was 95%. Predictive value of the test reached 100% and negative 98%. In some cases, we select markers based on the histological form of the tumor. And now I would like to show you our case. It was female, 69 years old. Complaints paroxysmal pain in the stomach, glandurally moving to the intestines, periodic bleeding from the rectum during defecation, and weight loss. Histological conclusion, moderately differentiated adenocarcinoma of a gastric with intestinal differentiation. And in this case, here you can see picture with cytology pictures, and I don't know how I can show you. Here you can see mitosis structure with polymorphism, and we don't know, maybe it was tumor cells, maybe it's benign mesothelium, yeah, proliferation mesothelium. And in this case, we use BRP4 and CK20 markers. Here you can see the picture with the immunocytochemical study results. BRP4 was negative and CK20 was positive. In the conclusion, the cytological exam is the only possible method for determining cancer cells in fluid, and therefore the only technique for detecting a microscopic lesion of the peritoneum in gastric cancer so far. Immunocytochemical study using a combination of monoclonal antibodies markers on cytological preparation, in some cases, or cell blocks, increase the sensitivity and specificity of cytological diagnosis by 46% and 20%, and the overall accuracy by 32%, which result is a more accurate determination of the stage of a tumor process, and will help decide on the tactics of each patient's treatment. And the use of only light microscopy to detect tumor cells in peritoneal washings is not enough, since cell elements subject to significant changes. Single cancer cells are difficult to differentiate among mesothelium, reactive mesothelium, histioid, macrophage, and another background elements. Here you can thank you for your attention, and here you can see my colleagues who support me to do this study. Thank you.
Thank you, Maria, for your wonderful presentation. Just want to know how will you differentiate when you are doing a psychological examinations in the peritoneal fluid, if there is a poorly cohesive tumor infiltrations into the peritoneum, how will you examine that fluid? So what should be your panel of IC marker?
Which marker we use?
Yeah.
In some cases, it's BRP4, only BRP4 marker. In some cases, it's BRP4 plus different marker, like in my case, for example, CK. Very often we think, at first we think about tumor form because we know it after histology verification, and in some cases we use very often we use only BRP4 or MUC5AC or MUC2AC.
Yeah, I would also suggest to add CDH2 in that panel. That will also help defining whether it is gastric origin or somewhere else. Also difference at the same time from the foaming macrophages versus the circulating cells.
Yeah, but in this case, in some cases we use CD 138. Yeah, of course, and in some cases we use mesothelium antibodies if we need it. Yeah.
Yeah. Okay, thank you. Any questions from the audience? If there is no questions.
Okay. It's my pleasure to introduce Dr. Carr, who is seeing this almost in European world. That is in trials pediatric cancer almost in biotherapy. And more cancers of seriously.
Yeah. Actually, I am a oncopathologist by profession. So I used to work in a multi-specialty cancer hospital. So 1 year back, I joined in Bristol Myers Squibb R&D Center in Bangalore as a molecular pathologist and a translational pathologist. There we used to work day in and day out in multiple biomarker and also finding out, dig down deeper into mechanism of cancer resistance. So before joining, my job was in giving only diagnosis at the Fortis cancer hospitals. So there I used to, it- am I audible? Yeah. So, yeah. So the traditional diagnosis is about giving diagnosis, staging, and guiding the clinician what exactly the tumor is. And the medical oncologist has to decide what treatment combination he or she has to give. But the the recent diagnostic, that is multimodal diagnostic approach, is something different. We can do different thing by adopting multimodal diagnostic approach. Here we have to, when I'm talking about multimodal diagnostic approach, that means I am combining pathology, genomics, artificial intelligence along with tumor microenvironment. If we have a deeper understanding about all this aspect, we can guide a medical oncologist to decide what particular treatment combinations is best for particular tumor. Also, you can find out or tell the clinician what is the cause of the resistance. So I will showcase this multimodal diagnostic approach through a surgical case-based approach, where I will walk you through one interesting surgical case. Uh, so this is a patient, 42-year female. She has been diagnosed with tumor ovarian mass and done surgery elsewhere, and diagnosis also done elsewhere in a tier 2 city. And they have given as a high-grade serous carcinoma, and simultaneously they have given cisplatin-based 6 cycle of new adjuvant chemotherapy. So after 6 months, the patient presented with multiple liver, peritoneum, and bone mets. The question about is that what is the prevalence of this second resistance? If something not working initially, that is called as prime resistance, means that is called as cisplatin resistance. So as you see, 20% go for prime resistance, and more than 90% go for this ovarian serous cancer, go for a second resistance. So as you can see, as compared to the prime resistance, second resistance has better survival. So the question about is, can we improve the survival benefit by identifying the cause of resistance, cause of relapse? For that, we need to understand what are the probable cause for any tumor, or especially ovarian cancer, can go for a secondary resistance. There can be multiple cause of relapse. That can be use of incomplete diagnosis. Diagnosis might be wrong, or might be failure to the conventional treatment. It's called as cisplatin resistance high-grade serous cancer, or it might be due to incomplete testing. So more testing need to be done to understand the better biology or deeper biology about particular tumor, or we need to understand whether it is a primary resistance or secondary resistance, or maybe we need to understand more deeper about the surrounding of the particular tumor. Surrounding means I'm talking about tumor microenvironment. For that, we need to understand what is the surrounding. So to target any tumor, you have to focus on the tumor microenvironment, that is surrounding. If you know the surrounding of particular tumor, a particular place, you can target that place in a better way. So in that logic, you need to understand what is tumor microenvironment. So tumor microenvironment, nothing but it composed of tumor as well as extracellular matrix. There is cells and lymphatic blood vessels, your T cells, B cells, or tumor-associated macrophages, or maybe myeloid-derived suppressor cells, and they usually cross-talk with each other. They cannot sit idle. They usually cross-talk with each other by secreting chemokines and cytokines. With this help, the tumor evolves in a very resistant clones, because they modify the tumor environment in such that the no drug can penetrate that. So they work in a very crosstalk manner. So by secreting cytokines and chemokines. So is there any way to target tumor microenvironment? Yes, there are multiple ways we can target tumor microenvironment. We target tumor microenvironment by polarizing the M1, M2 macrophages to benefit the treatment, or we can activate the anti-tumoral lymphocytes, especially the T cells. You can activate the T cells so that the T cell will go and kill the tumor cells. Also, we can target the fibroblast or inverse or suppress the hypoxia part, which is all these are related to the suppressive or non-conducive kind of microenvironment. Here, I've been focusing more on the neovascularization part, because my case is related to neovascularizations. First of all, we need to understand what is neovascularizations. If you see any histopathology report of liver cancer, they usually mention there is extensive sinusoidal capillaries. That is, and if you see the radiology report, usually they mention in the contrast CT, there is early wash out of the dye in the venous space. This is nothing but signs of neovascularizations. As you can see here, the normal liver, the SCC has extensive vessels. This is nothing but sinusoidal capillaries, and it is a signs of neovascularizations. And this tumor is primarily neovascularized, and some tumor, as they upstage, they get neovascularized. And this is typically about the ovarian cancer. Ovarian cancer, initially they are not neovascularized. When they upstage to stage 3 or stage 4, they usually neovascularize. As you can see, there will be the CD34 density will be increased. So the question is that what trigger for the tumor to go for a neovascularization? So for that, we need to understand what is happening behind the biology or in the tumor microenvironment. As you can see, as the tumor grow fast, they consume lots of oxygen. So the microenvironment become a hypoxic kind of things. So once there is a hypoxia, this HIF1 alpha protein gets stabilized. These proteins, they upregulate VEGF production. This VEGF-A, what they do, they stimulate lots of endothelial proliferations and this new vessel formations. And these vessels are not ideal vessels. They are leaky and chaotic. Means they does not solve the purpose of hypoxia, alleviating hypoxia. So what happened? The tumor go for a vicious cycles of hypoxia, ultimately changes to its metabolism. They go for aerobic glycation, where they produce lots of LDH. This LDH, what it does, it makes the environment heavily acidic. Once there is acidic environment, nothing works. Even if you add cisplatin does not cross that acidic barrier. Activated population like CD8 T cells that also stop working when there is acidic microenvironment. Also, other immunosuppressive population like Treg or amyloid-derived suppressor cells, they also start upregulating in this immunosuppressive microenvironment. So, is there any solution to tackle this environment? Yes, there is solution of everything. Also, a solution for this case as well. So, what we need to do, we need to add anti-VEGF therapy. You can go for any anti-VEGF therapy, that is bevacizumab or something else. Once you add the anti-VEGF therapy, what it does, there is the reason the VEGF production means there is a neutralization of VEGF, so that the acidic coverage happen optimally. Hypoxia goes down, the perfusion goes up. Means it is becoming a hypoxic to normoxic kind of environment. And all these suppressive cells like NTSC, Tregs goes down. Means the it is tilting from immunosuppressive to immunosupportive microenvironment. So this is the best time to add the immunotherapy. As you can see, there are so many immunotherapy available in the market. But right now, many big shot pharmas, they are working on the antibody drug conjugations, because they want to reduce the off-target toxicity. If you give any immunotherapy, there will be immune-related adverse effect. To reduce that, so the companies are coming with anti-VEGF and anti-medicines, especially Merck is working on that. So we can leverage by understanding the tumor microenvironment, how to tilt in the favor of immunosupportive, so that we can add the intended drug, which can work in the best way to treat that particular tumor. So coming back to our case, so what happened? So outside, they have given the diagnosis of high-grade serous carcinoma. When I saw the slides, as you can see, here the cells are arranged in a transitional manner. Because I'm a histopathologist, hardcore histopathologist. I can see the first part is it. It looks like, yes, it is a high-grade serous, but pattern is something different. It plays transitional pattern arrangement with loss of infiltration into lymphocytes, as well as loss of mitosis. So this is a typical variant of high-grade serous cancer that is called a SET pattern, high-grade serous cancer with serous, pseudointermittent, and transitional patterns. So usually 60 to 70% of this pattern of high-grade serous cancer harbor BRCA1 mutations. So next question is, what should you do to know the BRCA status? First of all, we have to send your FFP block for the BRCA NGS testing, and we have to send your blood samples. So we sent FFP block, then it came out that the testing NGS is positive for the only for FFP block. That means there is somatic mutations present in this particular tumor. The question is that what does BRCA does? So as you know, BRCA is responsible for double-stranded DNA repair. When that is missing, so what happened? Lots of mutation accumulation happens in that particular tumor. And all these mutations produce one new proteins called as neoantigens. These neoantigens taken by this MST class 1 and exposed on the surface. And that drags lots of CD8 T cells to the tumor microenvironment. As you can see, there's lots of intratumor lymphocytes. This is the compartment as well as the stool compartment. So this is the biology behind why this tumor is inherently hot. So we need to understand the biology. That's why we can know why this tumor is showing lots of inflamed lymphocytes. So if you see any text book, they usually mention that BRCA1 positive high-grade cell cancer, they harbor CD3 and CD8 inflamed lymphocytes. The question is that, shall we only depend on genomic test, because some of the countries, they don't have this NGS testing facilities? What to do? So do we have any deep learning platform to find out the pattern recognition? Yes, we have the deep learning platform available. So there are pattern like, so what does deep learning does? They extract the pattern recognitions. So this this set pattern of high-grade serous cancer, they have some typical morphological feature, like they arrange in solid pattern, they with high mitotic rate, and they have more tilts, and they have usually geographic necrosis. So this feature can be extracted or patch-based approach, means each patch is the size of 256 into 256 pixels. So each pixel then gives some probability score. That probability score can sum off and give the score. That can find out if the probability score is more than 0.8, there is a 80% or 90% chance that this case might be BRCA positive, or this might be BRCA negative. If it's showing a more than 80%, 90% chance, those cases should go for a actual conformity testing for genomic like NGS. So this is what AI can be incorporated into in the diagnostic field to reduce the cost and increase the precision. So coming back to our case, usually when there is a BRCA positive high-grade serous cancer, especially in SET pattern, they usually add PARP inhibitor. The question of is, can you add any immunotherapy like nivolumab or ipilimumab? The answer is, for that, we need to understand which are the tumor inherently sensitive to IO-therapy and which are the tumor are resistant to IO-therapy. For that, if you see this, those who have having IO resistance, immunotherapy resistance, they usually have this typical feature. They usually have high T-rate or myeloid derived surface cell infiltration populations, or high activities, or a specific amount of CD73 or adenosines. They usually have extensive neovascularizations, or they have like TG, TIM3 expressions. Alternatively, immune checkpoint expression is there in those particular tumors. These tumors are inherently, 90% cases are resistant to IO therapy. In other way around, if you see the IO sensitivity, so those who have high tumor medicine or more number of T effector or T cell populations or high PLN expressions or high mosaicode TLS density, especially the mature TLS, those cases are inherently sensitive to IO therapy. So with this understanding, we sent this block for a PDL1 CPS training, CPS scoring. It came out to be less than 5%, which is not a great score to start IO therapy. It is kind of disappointing for us that we are expecting the high PDL score, but it is not coming. What we did that we again sent that block for the tumor mutation burden analysis. As you can see, the tumor mutation burden is more than 50 mutation per megabase. So this is a kind of very high score to start IO therapy. So it is not that always we should depend only on PDL1 ISC to start any IO therapy. We have to incorporate tumor mutation burden because as you can see in this graph, both the disease is linear, but this is not excellent correlations. So it is like that there might be cases with high PDL1 with low TMB or vice versa. So you cannot rely on only one test to decide whether the patient is eligible for IO therapy or not. Also, what we did, we take a fresh tissue, fresh tumor tissue, and send it for the along with the patient's own plasma, and we send it for the ex vivo culture. What they do, they usually take the fresh tumor tissue, culture on the plate, and on that plate they divide different arms. One arm is only the control where they are taking, and they are the intended drug. I want to test for whether nivolumab is working or not. I added nivolumab in particular plate. What we saw, there is massive influx of CD8 T cells on the stromal component to intraepithelial component. You can see this fluorescent colored cells. These are intraepithelial lymphocytes which are migrated from the stromal component to the intraepithelial component. Why is it happening that? Once you add a nivolumab, what it does, it activates the T cells. The T cells secrete interferon gamma. Interferon gamma work like a chemotaxis. So they push lots of T cells to the stromal component to intraepithelial component. Once this activated T cell goes into the intraepithelial component, so this activated T cell secrete porphyrin and ganglion that perforate and kill the tumor cells. So as you can see, the tumor cells, as they're dying, they express more caspase proteins. It is a kind of apoptosis proteins. So you can see the caspase score has gone up, its mark K67 has gone down. Also, we said for the diagnostic analysis, it is a panel consists of IO360. Here, we usually see whether the nivolumab is working or not. There is a huge population of the nanosting panel score. All the inflammatory signature has gone up log two-fold. So this is nothing that if there is a high expression of this IO panel, IO360 panel, it implies that that tumor has become inflamed and nivolumab is working. So with this also we blocked some of the articles where they have mentioned use of Pembro in recurrent advanced ovarian cancer. So with all this evidence starting from ISC, your genomics, your nanostring analysis as well as multiplex immunofluorescence and article reference, convince the medical oncologists that the combination of what we are suggesting is working, and it is a kind of called as evidence-based medicine. So after 6 months, I got a call from my medical oncologist that, "Hi Pradeep, that patient has recovered dramatically, as you can see in cases to 1.1 criteria. Pre-treatment for MES was used. That has almost gone down drastically. Small MES, that almost vanished. So this is quite satisfying from a pathology point of view. What we hypothesized or suggested based upon all this evidence gathered from ISC to genomics, and that is working in a very efficient way in the patient, and the patient is quite happy and clinician is quite happy for that. So do we have sometimes we might get not only radiology images, also get the slides or FNC by or your FFB blocks or biopsies in neoadjuvant settings. to check for whether the patient is responding to a particular IO therapy or not. For that, we need to understand once you are adding a IO therapy, what all changes happens, what all things you will see in the slides to look for response or resistance. As you can see, once you add IO therapy, they go for three things. Means immune cell get activated, then that leads to lots of T cell infiltrations. These T cell can gather at one place for the T cell infrastructure. From that T cell infrastructure, then plasma cell development. So if you see all these things in the pharmacokinetics, then the signs of that particular drug is working in an efficient way. And also same thing, these activities start killing, you see the signs of cell death in the form of polycyclic or macrophages. Also, you can see the signs of tissue repair after this cell death. There will happen the tissue repair in the form of neovascular fibrosis. All these signs, sometimes you get in the lung biopsy to see for the signs of response, especially for neoadjuvant IO therapy. If you find all these features, you can tell confidently to your medical oncologist that that particular drug is working in an efficient way for that particular patient. And this pattern recognition can be trained and incorporated in deep learning platform so that easily algorithm can give a prediction score of 80 or 90%, so that you will confidently tell that the prediction score is around 90% or 80%, and that particular drug or drug combination is working in a very efficient way. So that's what the AI can help you in these particular cases. The question is that, is there any chance of relapse after this beautiful combination treatment? The answer is yes. Actually, okay. That study was 2019. So what if you see recent NCCN guidelines in 2023, Mr. have recommended it up along with in the high treatment medicine for ovarian cancer. AstraZeneca recommended for head serous or tumor. So what we have hypothesized in 2019, so same thing has been incorporated in NCCN guidelines in the 2023. It's quite satisfying that what hypothesis we have made based upon our learning and understanding of tumor microenvironment, that what exactly is incorporated by big pharma, and same thing has been incorporated into NCCN guidelines. That's quite satisfying. The second is that, is there any chance of relapse? Yes, every treatment there is percentage of chances of relapse. We need to find out what is the cause of relapse. As you can see, after a period of response, the tumor might proliferate. What is causing, what is the trigger for this relapse? As you can see, once the immune cell get activated, they start killing the tumor from the outside. T cells started, this boundary, the original tumor area. T cells started killing from the outside in pattern. So there will be always residual viable tumor. In core of the tumor, these residual viable tumor are the culprit. They are immunoedited clones. They are very notorious. They are the clones responsible for your secondary resistance and relapse. Why it is happening that? Because once you see this tumor cells exposed to T cells, what are these tumor cells? That's so clever. What they does, they downregulate the MSC1 expressions. Means MSC1 is the only protein that exposing the tumor neoantigens and calling the dragging the T cells. If I will not expose my MSC1, the tumor, the lymphocyte CD8 T cell cannot recognize you. So that's why what it does. So the tumor cells, what it does, it induce the methylation promoter region, it silence it. Silencing in such a way that the emission expressions goes down drastically. So this tumor is not responding to any therapy. So this is the cause why there is a secondary resistance and relapse after a brief period of response. And sometimes this complete pathological response, you can see there is complete minus. That's called as the pathological complete response. And sometimes you see only 8% of that is called as measured pathological response. So these two are usually right now in the recent trial, this PCR and MPR as used as a primary and secondary endpoint. As you can see, the recent breast trial for any nivolumab therapy, they have used pathological complete response as a primary endpoint, then measure pathological response as a secondary endpoint. So this is quite satisfying. Here the role of pathology is coming. So when you are scoring a tumor, particularly this will primary tumor, so I can score, give it 15% based upon the area measurement. It is very difficult task. Because it wants to be, you have to measure from here to here, and give what percentage probability is there. So literally, I'm doing a circle here, and in between another circle, and finding out and giving you a score. What percentage of residual viable tumor is there in the tumor bed? It is a quite cumbersome score. What we can do here, we can incorporate deep learning method where we can train the tumor component and not able right, by deep learning technology. And exactly you can find out the tumor area score. What is the percentage of area occupying for tumor bed? It will give the exact score. You take any example P1, P2, pathology 1, pathology 2, pathology 3, there will be no matching at all. If you take the help of AI, you can confidently tell that AI is giving to 20%. And that algorithm should go for a rigorous training, testing, and validations. And when I'm talking about training, testing, validations, you have to take if you are taking 100 cases, 100 cases, 60 cases go for training, then 20% case go for testing and 20% for validations. If the score, the dissimilarity score, it is a statistical score is more than 95%, then only you can take that to find out tumor stroma classifications. You can incorporate that deep learning platform, and you can find out exactly the value of the MTR is there, whether the 10% viability is there or not. That rigorous training is happening in the clinical trial setting, and they usually incorporate this to tell the FDA whether this drug is working or not, to take it as a secondary endpoint. It is that rigorous in the FDA point of view. The question is that how to know that the cause of MSC1 downregulations? There are multiple ways. You can do whole sequencing or epigenetic interventions. The most common cause of downregulation is epigenetic intervention. At any point of time, if anything is not responding, you have to first do a epigenetic testing. Okay, as you can see here, 50 to 60% is the downregulation is due to the MSC1 downregulation, or it is a part of the MSC1 proteins. This leads to the MSC1 downregulation. As you can see, histone DNA mutations, histone methylation, or histone deethylation. All these things leads to your less expressions of the MSC1, leading to the secondary resistance. The coming to the scope of AI, as I have told all through my slides how I am incorporating AI through calculating my antibodies. So we are using a CNN, convolutional neural network. So what it does is exactly what like our brain. Our brain has multiple neural layer. So each layer capture some of the parameters like pixel intensity, size, shape, or densities. All these things they captured by each layer, and these are nothing but the data. Means I'm taking a pixel density, size, shape, color. All these are going for a data. Each data they process in a complex mathematical model to give the output. How the output has given? For that we have to go for a digital pathology and AI integrations. For that, we will slides to a scanner. After that, we can incorporate the existing or developing synthesis algorithms. We pull out multiple parameters like your key 67 score, or in my cases, the sleep capture score by training cytoplasm and membrane staining, or for key 67, they are nuclear staining. For PDL1, that is cytoplasm or membrane staining. So also can classifier. I have told you regarding the tissue classifier algorithm for developing, for calculating the measure pathological response. You can do it to classifier. You can see exactly the area. You can mark this area, mark this area. Same thing should be captured by algorithms. So I have to compare this area divided by this area. So if that score is matching is more than 95%, that's called a dissimilarity coefficient. If it is not more than 95%, then only I can take forward that algorithm for my clinical use or trial use. Same thing can be done by tissue detection or modification profiling or area quantification for the any stromal marker. Sometimes for IO after giving IO there is extensive stromal modifications. There is extensive highlighting happens. So to capture that, also we are implementing a algorithms in our digital MSQ lab. So we can calculate the how much of the tumor area has been extensively highlighted because of the IO therapy. So this I'll finish my talk with a beautiful quote from Charles Darwin. It is not the strongest of the species that survive, not the most intelligent that survive. It is the one that is most adaptable to changes. We need to adopt new technology, new ideas, and integrate multimodal approach like understand your microenvironment or AI or genomics. We have to incorporate everything to find the deeper insight into the complex disease like cancer, or else we are very in a difficult position to fight a complex disease like cancer. So hope this talk resonated with you. Thank you.
Okay. Any questions from the audience? I guess if not, we'll do the certificate thing.
Next step is from Dr. Maruf Hamdas. What is that? Maruf Hamdas? Okay. So she's not there. We'll proceed with Dr. Akram Shamat. Thank you, Dr. You can introduce yourself and start with.
Hello, I'm glad to be here with you at this great conference. I'm a specialist gastroenterologist from Zurich Hospital, Sharjah. Actually, I would like to do this presentation about epic and heroic efforts done for this seldom and unique case. Fatal biliary tuberculosis complicated by obstructive jaundice and severe systemic conditions, DIC, ARDS, acute respiratory distress syndrome, liver failure. General considerations for biliary tuberculosis. Initially, I would like to clarify some facts about biliary tuberculosis. This disease is a severe and potentially fatal form of the disease that occurs when Mycobacterium tuberculosis disseminates throughout the body. Delays in diagnosis biliary TB can have dire consequences. The initial symptoms such as fever, weight loss, night sweats, and respiratory issues, often non-specific, and can be mistaken for other illnesses. As a result, healthcare providers may not recognize the severity of the condition until it has progressed significantly. Consequences of delay of diagnosis: biliary TB, increased severity, compromised immune system, hepatic failure risk, higher mortality rates, Up to 50% of miliary TB cases are diagnosed ante-mortem. My case, on the 18th of July 2024 at around 5 p.m., a 57-year-old female patient from Pakistan presented to the emergency department at Zuleika Hospital, Sharjah, referred from another hospital in Sharjah, with epigastric pain, jaundice, bilateral pedal edema, and shortness of breath. Labs revealed pancytopenia, deranged coagulopathy profile, deranged liver function, bilateral pleural effusion, pulmonary consolidation, and mediastinal lymph adenopathy. History of presenting complaint. Abdominal pain. She was complaining of abdominal pain localized to the epigastric region. Started suddenly one day ago. Progressive and sharp, radiating to the back, associated with nausea, shortness of breath, loss of appetite, and intermittent fever. Continuous but exaggerated after meals. Rated an 8 out of 10 on the pain severity scale. Past medical history. Non-case of hypothyroidism, anemia, taking treatment unknown, the treatment which taken before. Records show previous admission to another healthcare facility a month before presentation, unknown but found to have pancytopenia, deranged coagulopathy profile, bilateral moderate pleural effusion, consolidations, and mediastinal lymph adenopathy. Patient was admitted to another hospital ICU 9 days before presentation, having presented there with the same symptoms. No records of allergies, no records of any missed immunizations, no record of past injuries, previous stent placed in the of past injuries. Family history, no record of family history. Social history, patients denies smoking, drinking alcohol, or using any recreational drugs. Patients lives with husband in Sharjah, works as a housewife. Review of systems, no records. Examinations, general exam, patients looked morbid, skin was jaundiced, she was icterus, jaundice throughout the body, no nail bed, pallor or cyanosis, labored breathing, patient was alert and oriented, bilateral pedal edema. Examinations, abdominal examination, soft and lax abdomen, tenderness in the epigastric region, bowel sounds presented, respiratory and cardiac exams, crepitations were appreciated in several regions of the chest, especially in the basal. Cardiac sounds were normal. Vitals, heart rate of 124 beat per minute, respiratory rate of 30, temperature was 37.1 degrees, blood pressure of 120/80, saturation of oxygen was 96%. On 4 liters of oxygen, methods of administration not recorded. Differential diagnosis was severe acute pancreatitis, ascending cholangitis, cholecystitis, hepatitis. Actually, laboratories investigations showed deranged liver function, hyperbilirubinemia, elevated liver enzymes, elevated alkaline phosphatases, and prolonged prothrombin time and INR. Also reveals anemia with absolute monocytes count, low absolute monocytes count. Also thrombocytopenia, 26,000. Laboratory investigations, CRP was high, 71.7. amylase lipase CA199 were measured in another hospital where she was initially admitted before referral here to us. All their indices were highly elevated. ABG, as revealed, pH of 7.499, BaO2 232, bicarbonate of 30.8. Blood cultures all came back negative. Abdominal MRI without contrast revealed hepatomegaly with fatty infiltrations, enlarged pancreas with low signal density areas in common bile duct representing biliary sludge with mild dilatation of CBD and severe acute pancreatitis. Chest X-ray, anterior posterior view, confluent bilateral line consolidations, miliary obesities in both lines, obliterations of left angle, impression, pulmonary edema, possibly miliary TB. Here in this X-ray, chest X-ray, the miliary TB was in differential diagnosis. CT of the chest, thorax without contrast, there was bilateral pleural effusion, diffuse, innumerable tiny nodules in both lungs, possibly miliary TB, mediastinal lymphadenopathy also. Management. Admission. The patient was diagnosed with severe acute pancreatitis, primarily with ascending cholangitis, complicated by acute respiratory distress syndrome and DIC, with deranged liver function, for which she was admitted to ICU. Suspicion of miliary TB had to be confirmed by more testing. The patient was admitted to the Zuleika Hospital where she received IV fluid hydrations for pancreatitis and respiratory support through a high-flow nasal cannula, as well as IV antibiotics for ascending cholangitis. The patient also received vitamin K to mitigate the altered coagulation profile and blood transfusions, packed red blood cells, platelets, and fresh frozen plasma to address her pancytopenia and deranged coagulopathy. The patient was scheduled for an ERCP on the 28th of July during her period of admissions due to ongoing deteriorations of liver function tests. Multidisciplinary care. Pulmonologist consultation was requested immediately after ICU admission for her ARDS and her miliary TB signs on a plain chest X-ray and CT scan. Sputum culture and susceptibility requested but not done because no sputum. Mantox test done and result was negative. Hematologist consultation was requested immediately, also for her pancytopenia and prolonged prothrombin time, and informed that patients already has got many packed red blood cells, platelets, and fresh frozen plasma transfusions in another hospital where she was admitted and referred from it. ICU specialist consultation also requested for her critical status. Blood products transfusions. The patient was given 2 units before ERCP because she was suffering of severe thrombocytopenia and prothrombin time prolongation. Actually, a bold decision was taken to do ERCP for these patients without sphincterotomy because her liver function test and bilirubin was deteriorating. And after excluding and ruling out all other diseases, inflammatory diseases, the patient was given 2 units of blood, packed red blood cells, as well as an unit of pool platelets during her admissions. Below in the patient's CBC right after the last transfusions. After blood transfusions, hemoglobin become 9.8 gram per deciliter, and the platelets count improved after platelets transfusions to 36,000 actually. After ruling out all probable hepatic diseases, hepatitis B, hepatitis C, uh, autoimmune hepatitis, also Wilson disease, hemochromatosis, primary biliary cirrhosis, the decisions of ERCP is taken. ERCP on 8th of July 2024 is done and was indicated due to the obstructive jaundice and acute pancreatitis and ascending cholangitis, actually. Selective deep cannulation of the CBD done directly via sphincterotome over a pre-inserted pancreatic stent. Actually, initially I did a pancreatic stent because she was before already was suffering of tuberculous pancreatitis. I decided to set the pancreatic stent. Then I did also biliary stent. Common bile duct delineated via contrast material and cholangiography reveals a mild dilated common bile duct. Already, common bile duct was mild dilated on MRCP with a sludge inside CBD. Also, ERCP reveals mild dilated common bile duct. 5, both plastic stents, pancreatic and biliary is blessed in situ. 5 centimeter, 5 French plastic stents placement done successfully without actual, of course, without sphincterotomy. Definitely without sphincterotomy, because she was suffering of thrombocytopenia. We transfused platelets, pooled unit of platelets, also fresh frozen plasma, and vitamin K to improve INR, to improve platelets. At the end of the procedure, the biliary drainage was good. CBC, the platelets count increased dramatically and immediately after biliary stenting, and leaped from 36,000 before ERCP to 66,000 after only 24 hours post ERCP. And after 48 to 72 hours, platelets leaped till to 144,000 after 1 week post ERCP. She was suffering of severe thrombocytopenia. After biliary stenting, the platelets improved dramatically and leaped from 36 incrementally till 144,000 within 1 week. Liver function test, total bilirubin and direct bilirubin improved gradually after ERCP with biliary stenting till total bilirubin become less than 5 milligram. From more than 20 milligram before ERCP, after ERCP, total bilirubin decreased and dropped till less than 5 milligram. Abdomen ultrasound done and reveals normal CBD, no dilatation CBD with the plastic stent inside CBD. Discharge. Patient was discharged and advised to follow up for a second ERCP after 4 to 6 weeks later. Further investigations and treatment of these patients suspected TB was planned to be done after the resolution of the pancreatitis. Patients was discharged on the following medications: wide spectrum antibiotics because she was suffering of ascending cholangitis actually. Ciprofloxacin, ursodeoxycholic acid, dexlansoprazole, metronidazole, folic acid. This chest X-ray on follow-up at 6 August 2024. Second admission was on 26 of August 2024. Patient was admitted on the 28th August 2024 to undergo an ERCP for removing both biliary and pancreatic stents, since despite the CBD become normal and bilirubin decreased obviously to less than 5 milligram per deciliter, the liver function still deranged, and decisions had been made to undergo further investigations for TB. After improving platelets count, pulmonologists decide to do bronchoscopy and do biopsy, bronchial biopsy. Various liver function parameters were reinvestigated before the second ERCP, compared to liver function tests done before previous discharge. Total bilirubin less than 5 milligram, direct bilirubin less than 4 milligram, SGOT 124 still high, SGPT also 60 still high, ALV also still high 923. Repeat CBC. On the second admission, the patient's CBC obvious improving of platelets count, hemoglobin of 8 gram per deciliter. Second ERCP combined with bronchoscopy at 28, actually not 29, same day, 28, 2024 done. Both plastic stents, pancreatic and biliary, were withdrawn together via snare polypectomy. Cholangiogram reveals CBD 8 millimeter without obvious stones. Biliary sphincterotomy done successfully without any complications. TB investigations directly after ERCP, bronchoscopy done in same session. Several investigations were done during the patient's second admissions. Bronchoscopy was done on the same sessions during which biopsies were taken from the bronchos of the lung. Bronchoscopy itself revealed a normal mucosa with no abnormalities. Microscopic analysis of the biopsies revealed reactive bronchial mucosa with bronchial glands, non-necrosis or granulomas. Negative also for malignancies. Bronchio
Next speaker is Professor Dakyun Lee GPF. Okay. Next question is Dr. Jaya Jain. Please introduce yourself and start presenting.
Very good afternoon, everyone. Myself, Dr. Jaya Jain. I have done my pathology training from India, and I have also done fellowship in molecular pathology and genomics. And I was practicing as oncopathologist and molecular pathologist in multiple locations in India. And from past 2 years, I am working with Pramana, which is a US-based company, and we are providing digital pathology solutions. So today we are the topic of my talk is how autonomous volumetric scanning helps to promote the faster adoption of digital pathology. So just to go, yeah. So today we are going to discuss about digital pathology workflow, followed by challenges for clinical adoption of digital pathology, and what solution we have to make the workflow more efficient, and which includes autonomous volumetric scanning, inline slide quality control, as well as edge compute and inline algorithms. So the digital pathology integrate workflow has four important components. The first important component is whole slide scanning, which generate the whole slide image, which can be viewed on image management system. And image management system interact with laboratory information system, from where we can retrieve the patient test requisition form and other test result to interpret the data. And this data then go to the storage. Storage could be on-premise local storage, and it could also be cloud storage. So digital pathology has been present since past 2 decades. But still, as we see, the adoption of digital pathology is slow. So what are the challenges associated with digital pathology which are impediment for the faster adoption? So one important aspect is, like, still when we see the whole slide image with the current technology, we see that there are focus related errors due to specimen thickness variation. So specimen thickness, as we know, everything, when we cut the thickness inherent, there could be variation in the tissue. Like if we are having bone and soft tissue. So bone and soft tissue together, there would be thickness variation, and it is a 3D structure. And the thickness variation could also result from microtomy, like there are folds in the tissue. So because of that, the whole slide image will have focus related error. And another thing is, like before a pathologist is going to sign out a case using the digital modality, a quality analyst need to evaluate the slides for the quality, whether they are even acceptable for the digital readout as a primary diagnosis. So when we do manual whole slide quality analysis, then it is time consuming, costly, and also resource are required. And so this is another big impediment for adoption of digital pathology. Now, as we know, the main promise of digital pathology is like it will help us to leverage the AI algorithms in the routine primary diagnosis. So to avail that, we need cloud infrastructure, because initially you have to send the slide to cloud, and from in the cloud the algorithm will run and the result will come out, then a pathologist can evaluate that. And the another thing is all these algorithms are run sequentially, that is one after the another. So this prolong the time. First, a quality analyst will evaluate the slide and see the slide quality. And once it passes, then it will go for the pathologist to review. And in between, if pathologist is requesting an algorithm for a primary diagnosis, that will also take time. So overall, these are the current challenges in the clinical adoption of digital pathology. Now, how we are trying to address these solutions? Challenges. So first challenge, focus related error. To address that, we are doing autonomous volumetric scanning. What do I mean by autonomous volumetric scanning? That as we know that these tissue are in 3D plane. So what we do Z stacking across each and every field of view, and then we fuse it. So that way, everything, all the different areas of the given field of view would be in focus. And the quality analysis algorithm for the slide quality, we have those algorithms which are automated, and another part is they are inline. By inline, I mean they run in parallel to scanning. So these operations are running in parallel. So as this is running parallel in real time, it can give the feedback real time. So if rescanning is required, it can happen the same time, and you need not to retrieve the slide again, which can prolong the time. And another important aspect is if we use the cloud infrastructure, it is quite costly. And another thing is it can pose a security threat because we need to send the data outside the hospital premises. So what we are offering is Edge AI, that is compute power within the scanner. That scanner itself can be used to run the algorithm. As in the morning section, Dr. Ibrahim has discussed that cloud is very important. And for training of the algorithm, you need higher compute power. But what I want to say is like when you want to just the interference, just the inferencing part, that doesn't require that much compute. So that can be done with Edge AI. So as you can see here, every tissue, like whether it is histopathology, cytology, and bone marrow, we see that there is thickness variation. Like previous speaker has also said that they are not able to see 3D cluster in cytology because it is three-dimensional and it is present in different plane. In bone marrow also, if we go to marrow particles, it would be 3D. We won't be able to see it in digital pathology. So status quo is like everybody is scanning in a single focus plane, that is called as best focus imaging. How we are doing it differently is like we are doing the Z stacking and at each and every field of view, and we are treating it as a 3D object, so that whatever the area we are scanning, everything will be in the focus so that pathologists can report it. So here, if we see, like this is how the Z stacking is done. Like at every location, we are collecting the stack, and then these stacks are fused to get a fully focused image. So sorry, this video cannot be played, I think. Yeah. So coming to next challenge, that was slide quality analysis. So WSI slide quality has two kind of quality indicator. One is slide preparation related quality indicator. Another one is slide acquisition related quality parameter. So preparation related parameters include stain deposit, folds, bubbles, debris, misaligned cover slip. These are all slide preparation related error. And whereas we also have slide acquisition related error like focus error, stitching error, and faint tissue detection. So here, Pramana has the algorithms which run in parallel. So here, this is the tissue. Here we can see the classification of tissue versus debris and even the cover slip edges. Then we also make the focus metric map, stitching error map, and even the map for every AOI at the different Z level, so that every image is captured with the best quality. And for every image that we scan, we get a quality approved sheet where it will tell us about all the errors present in the slide. And if the error are above certain thresholds, then the slide will be automatically go into rescanning. So here we can see that the usual protocol is during the scanning itself, the quality check algorithm will run, and we will see that if it is auto QC, then it will directly go to storage, and around 85% of the slide are auto QC'd and rest very few will go into manual. So this way it can reduce a lot of cost, resources and time which is taken to do the validation of these slides. So usual workflow. So what I was meaning to say is like when you do the scanning and these algorithm are running in line. So this way, as it is running in parallel, you have real-time feedback. So if threshold is exceeding, you can do the re-scanning at the same time. But usually in the workflow perspective, what happened with most of the status quo scanning is that this case happens later. Like when they do manual QC, there would be a QC expert who will see the slide. And if he say that there are errors in the slide, then somebody has to retrieve the slide back from the registry, tissue registry, and then scan again. So that will prolong the TAT. Here with this, there is no delay in the TAT. And now talking about the AI integrated digital pathology workflow, as this is the main promise that with the digital pathology, we can enable the routine use of artificial intelligence based algorithms in the clinical workflow. So AI can be used in the pre-analytical phase of the workflow for case triaging, ROI detection, and also to fetch the ancillary test results. And in the analytic phase, it can be used for the diagnostic algorithm. And in the post-analytic phase, it can be helps to do the second read QC. So at present, the status quo is like this way. So every scanner, when we scan the slide will be uploaded to the cloud where it would be analyzed and the result will be sent back to the location. So, and this is done sequential in manner. What Pramana offers is like algorithms can be run within the system, that is at the same time, inline parallel, when the scanning is ongoing. And it is local, so there won't be any data security breach. And it as it is running parallel, it can give the result when the scanning is complete. So you are getting multiple benefits while the scan is ongoing. So this is the status quo, which is the sequential way where everything happens in a sequence. Whereas what we do, we offer the way where we are doing things, all the operation in parallel. Scanning is ongoing at the same time, inline quality analysis algorithms are running, and in parallel to that, image analysis algorithms are also running. So this way we are saving the time and we are also saving the risk associated with the cloud transfer. And another thing is it is way cheaper than the cloud infrastructure. So how this integrated workflow runs. So while this scanning is ongoing, there are two parallel operations. One is quality analysis algorithms and another is AI algorithms. And as we know, when we are digital, we also have the test requisition forms available. So from the test requisition forms, if we have the information of the case and slide, we can have the workflow modification, like we can triage the cases and we can also triage which algorithm to run in which particular case. So with H&E image analysis, we can also do ROI identification and also the block identification for IHC, for special stain, and for downstream molecular testing. And also it can do the automated registration of HA image with the IHC for tumor mass transfer, because as we know, we identify tumor and everything on the H&E image, and IHC is just for the biomarker quantification. So this way it allows the efficient use. So when pathologist is doing the case review, he has all the things handy. He has a QC approved slide with algorithm output using the HAI. So let's understand it by taking an example. So from the image management system, we have a case listing, and from the test requisition form, from the block description, we have the labels for the cases. So this can help us to easily utilize which algorithm can be put in which case, and this could be automated. Like as for example, in the section related to tumor, we can run the algorithm for tumor detection, mitosis count, TILS detection, algorithm for perineural invasion and lymphovascular invasion. Whereas in the sections for lymph node metastasis, lymph nodes, we can run this algorithm for lymph node metastasis detection. So this way, when pathologists need not to wait to start the algorithm. If we have everything in the workflow, then this can work on its own, and when the pathologist is coming next day he can get all the output ready so that it will improve his efficiency for the sign out, primary sign out. And likewise we can also run the MSI instability test for the this particular case, like in the IHC biomarker slides. And it can also, so like as it identify the labels and it know the complete case, with this system you can also do the registration of HNE to IHC for tumor mass transfer. So this is how the overall workflow look like. Just after the specimen receiving, we have the grossing, and from the grossing section, we know what are the blocks and that we have cut. From that block and slide information, we can do the case triaging. So for example, in the tumor section, we can run the ROI identification algorithm or histologic subtype and grade. So here, if we take this example, here red color indicate tumor, whereas this black color indicate necrosis, green color is stroma, and yellow color is inflammatory stroma. So another thing is like efficient use of resources. So when we are running an algorithm, rather than running the algorithm throughout the slide, we can select the relative location where it should be applied. That will save both resources as well as time. So as we know, we want to count mitosis only in the tumor area, not the rest of the slide. So that way, if this funnel approach will work, like only in the red tumor area, we can do the mitosis counting algorithm. Same way, tumor infiltrating lymphocyte count you want to do at the tumor at the edges, like at the tumor front and at the periphery of it. So we can do that. Similarly, here we can say in the IHC section, using the HNE image, we can also do transfer of the tumor mask. Because as we all know, in the breast cancer cases, like you will have the tumor and sometimes you will have normal duct also in the same section. So, but you don't want to, if you are doing an automated biomarker quantification, the algorithm just identify the positive and negative cell. But for proper identification, you want to count only positive cells in the tumor area. So this then tumor mass transfer become important. So this is a funneling approach which works very well. And this is how complete workflow will look like. So inline edge AI integrated algorithm schema. So first, if you see, first, whenever we are seeing the image, we will see the tumor classification. And along with that, when you are running the nuclear classification with it, so together we can have the morphological segmentation, like classification of different areas versus tumor versus normal stroma versus inflammatory stroma versus adipose tissue versus necrosis. And using this, and when we do the transfer to the IHC slides, we can also have the counting of ER, PR, and HER2/neu only in the relevant tumor area, not in the normal ducts within that area. So this is the complete workflow. And to conclude, here I want to show you that how everything is running in parallel. So if you see, this is the grades, like entire biopsy is divided into small grades. And then when scanning is happening, we are collecting the stack here. And as we move to second location, in the previous location, we do the algorithm run. Because anyway, when we run the algorithm, we run it on a small patch. Like algorithm can run at a time at 256 by 256 patch. So it doesn't run on the whole slide image anyway. So we want to utilize that thing to save the cost and give a more efficient outcome. Because in cloud, you are sending the entire slide, but still there also the algorithm will run in a small batch at a time, 256 by 256. As we are sequentially collecting, going from one position to another position to collect the stacks and do the scanning. At the same time, you can run the algorithm in the previous batch. So first we can run the algorithm for quality analysis. So like here we found that this particular AY is going out of focus. So at the same time, without causing any extra tight delay for the slide retrieval, we can recover from that. We can start the inline rescanning here. And it also allows us to estimate how many stacks are required. We are not taking like 7 stack at every location. We will do like, if it is a 3D cell cluster in cytology, we can go up to 11 stack if required. So we estimate different Z planes and identify how much is required. And here, as we are scanning this, we are running QA algorithm here. We can start the running of AI related interpretation algorithm or diagnostic algorithm in the previous scan. So that way, using this scanner compute itself, we can have the entire algorithms running in parallel to the scanning. And that way, when the final outcome is there, pathologist has all the pieces of puzzles together. The QA approved slide, and also the algorithm output. And also, as it is workflow related, if you have the entire digital solution, image management system and LIMS talking to each other, then you can also do the triaging of the cases and also selection of slide which algorithm to run. Because nowadays, after certain time, there are n number of vendors offering the algorithm for Gleason scoring. So which algorithm to run? And also, you want to run the Gleason scoring algorithm only in the prostate tumor section, not in the lymph node section, or not in any other place or the margin section. So that way it also optimizes that. So this is how the future of digital pathology will look like. When you are scanning the slide, you also have the digital test requisition form with output, NLP output, that's natural language processing output. That is, it will help to identify the different types of blocks from reading the text. And as it is also integrated with LIMS, so you will have the ancillary information like physician notes, clinical details, radiology, CT, MRI, and lab reports also available. And then using these, we can have the slide level algorithm suggestion and output. And it can also help to do the interactive auto annotation tool. And with these, it can help to provide the suggestions for IHC. Like if we know that this is a case for a particular type of case, and if we have the knowledge tool built, then it can help to give you the suggestion for rest of the cases from the existing records. Like this kind of cases, this kind of IHC can be done. So this can suggest that also. And if your case is very difficult and very rare, it can also help with similar case and image search. And this way, you can do the synoptic reporting, overall reporting in a digital environment, and you can also track your addendums and amendments if required. So thank you for your patient listening. Thank you. I'm open to questions.
Thank you, Jay, for elaborating and very deep, insightful talk on digital pathology, especially that jet stacking and your autonomous volumetric scanning. Just I have a couple of questions.
Yeah.
How your platform is different from the competitor? The competitor like Hello, Visual, they are also coming up with inbuilt algorithms, and they have tested in multiple scanner. It is kind of called a scanner agnostic.
Yeah.
And different region, hospital, they have tested is a huge amount of data. So how your platform is better than them?
So first of all, we are not selling it as in like algorithm platform. We are algorithm agnostic. We are welcoming even Visioform, Ibex, and all the algorithm vendors. That's why I was saying that if somebody has n number of algorithm, they can choose. So we are providing the scanning solution and the compute within the scanning. And we have our inbuilt AI algorithm, very few. It can run together. So we are presenting the concept and the platform so that third party can also come and plug in their algorithm. What we are saying is like, rather than we are improving the workflow, rather than using the cloud pathway, they can run. So recently only we have the just a tie-up with the Gestalt. Gestalt is having a mitosis algorithm. So their algorithm is safe within our environment because it is in a Docker. We don't interact, we don't change anything. It is in a Docker format. It runs within our scanner. So that way, what we are offering is like a scanner agnostic, not scanner, algorithm agnostic platform, and you can run all the algorithm together. And another different point, as you have asked from the competitor, so one of thing is scanning. Most of the scanner, every scanner, they are doing west focus imaging. So that is scanning in one plane. They have extended depth of focus, but if you ask them, then the time is that usually everyone say that the scanning time is 15 for 15 into 15 tissue is less than 60 seconds. But same question you ask that we want to do with extended depth of Z, they will say multiply it by number of layers you are taking. If you are taking 11 layers, then it would be 11 minutes. But for us, we do default and same area we can scan within 3 minutes, and you will have multiple output. What outputs you are getting apart from scanning? You are getting first default Z stack scanning. That is like everything is in focus. Then you have the QA approved slide with the results also available. That this slide is QA approved, what were the number of focus error, percentage of other errors also. And at the same time, you can also run the algorithm. So it is very different from the competitor.
One problem we are facing in day to day is that if some algorithm has been developed, we are developing at 20x, then the scanning has been done in 40x. And they told to run that algorithm in the 20x or 20x developed algorithm in that 40x scan slide. It is not working perfectly. We are not getting the optimal that matrix score, be it your dye-similarity coefficient or your sensory specificity. So that part we need to take into considerations. As well as that you are depicting about tumor stroma classifier. That classifier is applicable when the tumor is in ideal category, like all differentiated. When you find, especially for gastric cancer, you are finding a poorly cohesive cancer.
Yeah.
That cases your algorithm badly fails.
Yeah, that I agree. So what I'm offering, what I'm saying is like I completely agree to you. This is the phase where AI is still in the development phase. It hasn't come into clinics yet. It is like right now people are experimenting with different concepts, and even many things need to be standardized within the pathology community. Right now, the staining itself is not standardized. You go to different scanner and there would be slight difference in the color and the algorithm need to be retrained. So for this, there are multiple standardization needed at all the levels. And the algorithm also, if you are training at a particular type of slides and particular case, then also you need to retrain it when you are dealing with different, whether it is like 20 to 40x scanning or even the different scanner or all the variability. And another point is like depending on the difficulty of the case. I totally agree with you. We ourselves was trying to differentiate. So AI algorithm in the current phase, they are good with the stage, like you can say grade 3 cancer, where the cancer cell are very different from the normal cell. As soon as you go to grade 1, it is difficult for AI algorithm because in grade 1 cancer, we as pathologists also, we rely on the architecture also, not just the cell. And what algorithm see is a patch of 256 by 256. In that there is nuclei. If I myself see as a pathologist, sometime just the nuclei, if you blind me for the rest of the area, you're not giving me architecture, I can't tell you whether it is a normal nuclei versus grade 1 tumor nuclei. If it is a grade 3 tumor nuclei, definitely every pathologist will say that this is abnormal. So we are slowly, I assume that slowly we will move there, we will get there because algorithms are getting better and better day by day. With more data, more digitization, we will have more sample points for better algorithms.
Thank you for your answer. And any questions from the audience?
Thank you very much. I believe that was very great, especially anyway, you have integrated a lot of factors into your design. So I had two questions. One is specific about the bone marrow assessment. And as you mentioned, thickness of the smears and pickles, it's one of the challenges. And the second issue, it comes to higher magnification that we need to scan slide by objective of 100. And even sometimes on lymphoma cases, even on H&E, I would like to go to magnification of 100 and see exactly the cytology of the cells. So first, have you come up with any solution that resolve that issue? And my second question would be, as we are moving forward, now we have an integrated AI-based, platforms integrating clinical radiology, all of those things, and specifically clinical decision making is an important factor now coming in. So, is your system also open to be connected to clinical decision making systems? Thank you.
So, very good question. So first, to answer your first question, so we have tried with that. The thickness will definitely vary. And your question was about changing the objective to higher magnification while scanning. So what we do as we are running, so this is right now in the R&D phase. What we are planning to do is, like, as we are going forward with the scanning, if we identify the area, like by the parallel running the algorithm in parallel, then we can move the turret and go to higher magnification in those particular areas, so that because you don't need higher than 40x in all the areas, and because there is always a trade-off between time to scanning and the quality. Because if you scan a slide, complete bone marrow slide at 100x, then it will take forever, maybe more than 1 or 2 hours to scan the slide. So to have an efficient way, that because 100 like more than 100 minutes for scanning is not feasible in a clinical setup. So to get a sweet spot, what we are thinking is, like, we will scan at 40x routinely, and in a selective location we will go to higher magnification as and when required. So this is a feasible thing, and we are doing R&D on this. And the second question was related to integration with the ancillary results. So, what I was presenting, our company is mainly providing the scanning solution, and we are agnostic to any image management system also. So, even if you are going digital, you can use, like, you can use Sectra image management system, or you can also use Procia. And image management system, if they have integration with LIMS, they can pull out anything. So it is just the integration with LIMS and EHR. So that depend on what particular LIMS you are using in your setup, and whether the vendor is open to integration. Because we as a company, we can have, like, we can interact with them if they open their APIs for us to interact. So it is like collaborative work with the vendors. Yeah, but it is doable.
Okay, if there is no more questions, then thank you and collect your certificate. I think for today it was the last talk, and after this we can go for a coffee break, and we'll finish the session today itself. Tomorrow the conference will be reaching at the same time, 9 o'clock. Yeah, 9 a.m. Thank you.